Yeah, good morning. Can we have your attention? So we are starting. Yeah, and I would like to make some announcement before handing it over to the chair and the presenters this morning. So, first I'll start with the Global Fund per diem. So, because there are so many questions coming to us regarding that. So, for those of you asking for the Global Fund per diem, please, you can go to table 14. Melanie will answer any question. Melanie, maybe you can stand so that they can see you. Yeah. Okay, so then the other thing is about payment for the taxi transportation to the airport. So we mentioned it yesterday. So, and you can go to Queen during coffee breaks and lunch. So, and the last thing is that today we'll have a dinner. So, and we'll have buses coming to pick us. So, and we should be ready by 5:45. Yeah, and also we have a request, please take your name tags along with you. Okay, thank you. So we'll hand it over to the chairs.
Good morning, everybody, and welcome to day 2. We have a very interesting, I think every day is interesting, but today we're moving through the cascade. So yesterday we looked at screening and TB infection, and now we're moving through the cascade to TB diagnosis, and we have a very interesting day ahead. And I think just at this early stage, we have a lot of sessions for discussion. And this is the key reason why we're all here, is not only to get updated on the latest guidance and the evidence behind that, but is to really hear your reflections, any questions you have on where the guidelines have come from, but I think more importantly, your experience of implementing the challenges, and probably most, and really your ways that you've overcome some of these challenges, how you're scaling up these new guidance, and really experience share amongst us all. So we will, at the Q&A sessions, be putting lots of people on the spot. So if you don't want to be put on the spot, get ahead of us and put your hand up and share your experiences. So without further ado, I'm sorry, I haven't introduced myself, but I was on the stage yesterday. I'm Grania Brigden from one of the senior TB advisors with the Global Fund. But without further ado, we will start our really fascinating day on diagnostics today. And I'd like to introduce Dr. Patricia Hall Edison from the WHO Global TB Program and for lung disease. I might have got something like that, Anna, but her bio is in your files. And please, Patricia.
Good morning, everyone. I hope everyone was able to get some good rest yesterday before starting our diagnostics journey together today. So yesterday we covered TB infection testing, and just as a quick overview, today we'll be going through the diagnosis side of testing and then drug resistance. So we're kind of completing the testing cycle. If you've had a chance to look at your agendas, you'll see I'm up here a few times today, again, on behalf of the team. But the idea really is, as Grania rightly said, for it to be as interactive as possible. So we're really looking forward to your inputs during the discussion sections as we go through some of the new policy updates. I'm going to try to make this more seamless today in the slide transitions. Well, I'm trying anyway. Okay, so these are our objectives today. So just starting at the beginning, I'm gonna give you an overview with the introduction, goals, and objectives, and then we'll do a little bit of scene setting with where we are with data for TB diagnostic testing. So the first 3 goals or objectives are presented here. So to review the global TB testing priorities and regional progress toward universal patient access to diagnostic and drug susceptibility testing services. We'll learn about the new WHO TB testing policy and operational guidance that's forthcoming, and some of the recent additions that have been added through recent rapid communications last year. And then consider how the new WHO guidance could strengthen regional and country testing programs for target achievement. And that will help us to kind of proceed into the strategic planning session at the end of the day. Okay, so this is our agenda. Again, we're going to go over some advances globally and regionally in testing programs for TB, looking at some of our global data, some of the regional data, and some of our diagnostic-specific data capture efforts. Then we'll talk about the policy updates, again, on TB and drug-resistant TB, specifically focusing on some of the low-complexity assays and testing for persons living with HIV and for children. And then we'll go into drug-resistant TB testing updates before getting to our working session. Okay, so starting with the global and regional TB testing priorities and progress. So we know that TB testing is essential to achieve NTB targets. And so just to ground us in the overall NTB strategy, I've highlighted here that Pillar 1, which is integrated patient-centered care and prevention, has 2 sections or focus areas related to its components. Early diagnosis of TB, including universal drug susceptibility testing and systematic screening of contacts in high-risk groups, as well as preventive treatment of persons at high risk and vaccination against TB. So the prevention piece is related to yesterday, to the TB infection testing, but it's all part of the same testing programs. However, despite these WHO recommendations, and we know this, and Cecily covered some of this information nicely yesterday, as did some of our colleagues from headquarters during their presentations, we know that approximately a quarter of the world's population is infected. Of the 10.8 million incident cases, approximately 8.2 million were notified in 2023. This is again according to the 2024 Global Report. And while that was an increase in overall case notifications found, there's still a gap between those two, suggesting that we need to advance further for TB case detection. Of those 8.2 million notified cases, only approximately 48% of them received initial diagnostic testing with a WHO recommended rapid diagnostic or a WRD. So this is a little bit less than half, and we're going to dive into this a little bit further in a moment. There were also approximately 400,000 rifampicin resistant and multi-drug resistant TB cases, and unfortunately, less than 50% of the drug resistant cases estimated were diagnosed this same year. When we look at drug susceptibility testing, which is essential to identify these patients and guide their treatment, we see that approximately 79% of bacteriologically confirmed cases were tested for rifampicin resistance, and then the numbers start going down for drugs further on in the chain. And so we're going to talk about that a little bit more this afternoon. 55% were tested for fluoroquinolone resistance. That's among those with rifampicin resistance. And then there are low rates of bedaquiline resistance testing globally. So I'm just going to take a look at each of these in sequence so that we can kind of compare, since we're here for the regional workshop, where are the regions and what is the global overview? So this is WHO recommended rapid diagnostic testing among new incident cases of TB in 2023. And you can see that the percentage overall has increased greatly over time, which is nice to see, and is largely dependent on introduction of Expert MTB-RIF Ultra, of the MALBIO TrueNat assays, and other rapid diagnostics that include more rapid diagnosis. But a large proportion of this, so only 48% of these patients received this testing in 2023. And you can see that plateau globally. We're not increasing at the same rate for the past couple of years. When we look at the regional pictures, these look very similar, although I would say Western Pacific has this nice increase above 60% here, but you can see this plateau on both of these graphs. And so looking at how can we address and continue to increase that curve is something that we're going to talk through today. When we talk about rifampicin resistance testing among the bacteriologically confirmed patients, we see that in good news, both of the regions, in addition to the European region, achieved greater than 80% coverage of bacteriologically confirmed patients. This was the data reported. This is really great news, and again, is dependent on advances in technology and new diagnostic tests coming forward for recommendation and for uptake by all of you in the programs. This is really nice to see. I would highlight that in the Western Pacific region, we have a little bit of a plateau for the past few years. So this was achieved, and now it's kind of plateaued and even a little bit down this year compared to previous years. So something for countries in that region to consider. When we look at fluoroquinolone resistance testing, again, among rifampicin resistant cases now, so continuing down the drug resistance testing cascade, we don't see, unfortunately, those same high trends. We see an increase recently in fluoroquinolone resistance testing in a lot of the regions, which is good news for patients and drug resistance control, but we tend to see that these fall below 50% in both of the regions. We're not quite achieving the coverage rates for second-line drug resistance testing. And I just want to highlight for a second that drug resistance for fluoroquinolone resistance has been elevated in WHO as a priority and is reflected in our latest target product profile for the development of new drug resistance tests, because this information can inform both dosing for drug susceptible patients as well as treatment for drug resistant patients, right, as far as their regimen construction. When it comes to bedaquiline resistance testing, I'm showing this map here so that you can each locate your regions and countries. But in general, rates are fairly low and variable. And we understand that there are a lot of practical reasons behind this. The drug powders for drug susceptibility testing, for example, weren't available in many settings or were challenging to access for a while. And now they're becoming more widespread as we build capacity for testing. In many settings, the drug resistance treatment regimen, BPAL and the BPOM, were rolled out in advance of testing for resistance. So we understand that there is to be a lag, but this is an important aspect for testing programs to follow up on. And then when we look at global linezolid testing, it's very similar. So we see low rates, variable, but they tend to be fairly low. And again, this is expected. These are new regimens. We're building capacity, but it would be great to see this capacity increase. Okay, so this brings me to tools and materials that we have in talking through patient access and ways to improve patient access over time. So in 2023, WHO launched the WHO standard for universal access to rapid TB diagnostic testing. And this covered 4 areas of the cascade. Step 1 was identifying presumptive TB. Step 2, accessing testing. Step 3 is patients being tested. And step 4 is those receiving a diagnosis. And there are 12 benchmarks within this standard. For those that had already looked at or worked in advance on the Excel spreadsheet on diagnostics that we'll use later in the workshop at the end of the day, some of these benchmarks are reflected. Some of the language in the benchmarks are reflected in that tool. I'm going to quickly review the benchmarks, and then we'll kind of move forward in our agenda and look at a little bit of reporting. So benchmark 1 here under identifying presumptive TB is that all household contacts, PLHIV, and other locally relevant high-risk groups are screened for TB. Benchmark 2 is that in all districts, chest X-ray is used regularly for TB screening. In benchmark 3, now moving into step 2, we have in all facilities in all districts, the algorithm requires the use of WRD for the initial diagnostic test for TB. This includes PLHIV and use of the LAM assay, which we're going to talk about later today. All primary healthcare facilities have access to WRDs. Benchmark 5 is that all individuals with TB have access to WRDs as their initial diagnostic tests. Benchmark 6 is that WRD testing capacity meets expected needs, including surge capacity in areas where you are anticipating to identify more cases or where there's active case finding going on, for example. In step 3, we have 3 benchmarks. These are 7 through 9. So with 7, we have that all functional instruments have an error rate of less than or equal to 5%. This is a very laboratory specific indicator all of a sudden, right? You've got primary healthcare facilities, patients receiving testing, and then all of a sudden we're looking at error rates. But this is an incredibly important indicator for quality monitoring for testing. We want to make sure in this benchmark that the services that are being provided and the patients that get a test are getting a right test and that services are functional. For benchmark 8, we have all individuals with presumptive TB being tested with a WRD, all patients with bacteriologically confirmed TB undergoing universal drug susceptibility testing for at least rifampicin. In step 4, we have benchmarks 10 through 12. So 10 is all patients with pulmonary TB receiving an initial WRD result to inform their diagnosis. So not just tested now, but they get the result back and a clinician can use that result to make a decision. Benchmark 11 is that all districts monitor the test positivity rate to optimize the impact of screening and testing strategies. And then benchmark 12 is that all TB testing laboratories achieve a turnaround time of less than or equal to 48 hours. And this is one where we know anecdotally and from other data sources and surveys that have been done has been very hard to achieve despite the introduction of these low complexity tests, which can challenge access. In some settings, turnaround times have been reported of up to 11 days for example, gene expert testing. And so this is something that it would be good during our discussions on access to get your experience and feedback on. It's also a topic that can be addressed in day 4, I will say, as we're talking about patient access and market shaping and new diagnostics and use cases. Okay, so after the launch of this, countries member states were invited to report on the standard. And this, what I'm showing here is the reporting progress across the benchmarks by all the countries globally. So there were 65 countries. Priority countries, these included the 30 high TB burden countries, as well as priority member states that were raised by our WHO regional offices for reporting. And because this is a first year round of reporting, we understand that not all member states were able to report on all of the benchmarks, including the denominators and the numerators. So for example, if you have a benchmark of all persons with presumptive TB were tested with a WRD, you need to know how many people were tested with a WRD and how many presumptive TB cases did you have. You have to have both of those pieces of information in order to report on that benchmark fully. And not all programs had access to all of that data that underlies each of the benchmarks. And so this is the number of countries shown here in the bar graph that were able to 100% report on both aspects for each indicator. So they were able to fully report on the benchmarks. The first 2 are in step 1. So this is the percentage of people screened for TB and the percent of districts with chest X-ray. This is step 2, step 3, and step 4 here. And you can see that some countries were able to fully report on, and it's largely because the data points here were dependent on data points that are already reported for the global TB report or essential indicators for TB programs. Whereas there are others highlighted here with the stars where many member states were unable to fully report on that benchmark. And this can signify that the data was either unavailable or it simply wasn't reported to WHO during the first round. Countries are undergoing a second year of reporting now, along with the Global TB Program report data indicators. So this will be built in to the reporting cycle, and we'll be able to report out on that. We're hoping to provide an update at the Union Conference later this year. What I'd like to highlight with the stars is just these points that don't have 100% completion or where countries globally were unable to report fully are often related to the proportion of people screened to either being familiar and understanding the number of presumptive individuals, so people with presumptive TB that you have in your communities in order to be able to report on that. That information we've learned from countries through back and forth discussions is not always available. And the second piece that I'd like to highlight is the test monitoring. So positivity rates here, and also the error rates. So these are laboratory and performance indicators. And those are often, or sometimes, depending on your setting, not integrated for reporting. So that's something that we also want to be able to keep an eye on. Because these are the benchmarks that WHO will be collecting data on now annually. It's really important that we understand what are the challenges in being able to measure this, because these are the proxy indicators for programs being able to measure patient access to testing. So we're going to be able to work towards understanding where are there gaps in services and where are there gaps in data, essentially. And it will be good to discuss this a little bit more today. This is the results for the combined countries from these two regions. So when we just take away everybody else in the world and we focus just on these two regions, we see actually a very, very similar profile. So there were 13 countries that were invited to report on the standard benchmarks in the first year. And you can see that particularly for the percent of people screened for TB, the reporting was quite low, being able to have both of those data indicators. This relates back to the exercise yesterday where we're looking at strategic planning for screening and considering how data availability and how program access to data could impact the measurement and the planning around those services. I think I'll leave it there. The slides will be shared with you. I will also say, however, if you go to the Global TB Report website, there is a data section on the website. And under that data section, you have access to all of the countries. This is public information. You can go look at your country's report and exactly where the data was available and what was reported for each of you. Okay, so in summary, for the opening and the scene setting for where we are with looking at global access to testing, coverage, drug resistance testing, and the global priorities, access to WHO recommended rapid diagnostic testing has increased quite a bit over the years, but we still have a ways to go. Drug resistance testing has also greatly advanced, but is in many settings limited to the first-line drugs, so second-line drug resistance testing will be essential. And the WHO standard for universal access to rapid TB diagnostic highlights the availability and importance of this data in order for programs to be able to track access to testing and coverage of testing services, and opportunities to improve these with new reporting cycles and with new looks at your strategic planning and how that relates to how you're monitoring some of your strategic plan actions. And so we are working towards advancing WHO policy in order to strengthen some of these areas and to look at differentiated service delivery for different patient populations, which we'll talk about in the next presentation. So with that, I believe that is the end of this. I am happy to take questions from the opening presentation, anything around the data or global access or the scene setting. Then we'll head into those policy guidance overviews and at the end of the day, work towards putting it all together. Thank you.
Sorry, I'm Jennifer Fern from Treatment Action Group. Thank you for the great presentation. It's nice to see the focus on diagnostics, particularly with benchmarks. My question is about whether there's any consideration in the benchmarks for looking at the diagnostic services being provided free of charge. Many people do incur catastrophic costs while they're undergoing diagnosis of TB treatment. And there's a lot of attempts to make access to treatment free, but in the diagnostic cascade, patients do incur a number of costs. So just wondering if you could comment on this. Thank you.
Yeah, no problem. So the accrual of catastrophic costs is covered by global TB report indicators and reporting. But in my knowledge, I don't believe there's specific information related to the cost in this particular standard for access. But it is a very important consideration. Happy to talk about it more, how to potentially look at ways to link the data sets. Okay. So moving right along, this is a lot of my voice. Said I was going to try and vary my volume.
Maybe we can ask each and every of the countries, a representative of each of the countries, if you are able to say how many or which proportion of your population is annually tested for TB. Yeah, so which proportion of your population is annually screened or tested for TB? I know, for instance, Vietnam can say it. So maybe if I ask Vietnam directly. Dr. Hoa, I'm putting you on the spot.
Yeah, in Vietnam, for testing for diagnosis for TB in the year 2024, we have diagnosed about 113,000, and we have spent this nearly 60,000 test experts for this testing positive is about 113,000 expert positive. Among this is a test, but among the people is the TB patient is getting the expert on diagnosis is more than 60%.
Yeah, thank you very much. So now the question you're now answering is which proportion is getting a WHO recommended rapid molecular test. But my question actually was, how many people are being evaluated for TB or are screened for TB? So that means the people being tested, being screened, for instance, chest X-ray screening, yeah, and then evaluated for TB, plus all the people who are getting a sputum smear or any other test. And I think in Vietnam, it's around, it used to be kind of 0.9% of the population getting a smear test. And then on top of that, the people getting a chest X-ray.
For smear test is around 700,000 get the smear test per year. And this is for the people screening for chest X-ray for screen for TB. Is it more than nearly 1 million.
So I think here we are getting out how difficult it is to know how many people are tested or evaluated for TB in the first place.
Yeah.
So would you have a definition of that? Because now we're only talking about the people who get a sputum smear. So those are the ones who have gone through some kind of evaluation in a primary care clinic and end up with a sputum test. Mm-hmm. There's overlap between the people tested with sputum smear and tested with the expert. Mm-hmm. And there's overlap between the people tested with a chest X-ray, screened with a chest X-ray, and the consecutive testing, sure. Laboratory testing. So would WHO have a good definition of the denominator of the people tested for TB?
So if I understand the question, and then colleagues can also weigh in. So for presumptive TB, as far as eligibility for initial diagnostic testing, it does vary a bit by recommendation depending on the population, but it is generally those that have screened positive or have signs or symptoms of TB in order to receive initial diagnostic testing. Now, what you're talking about, I think, is a little bit upstream of who should be screened.
No, actually, I mean what you're saying.
Okay.
What you're
so
saying is
any
people
who have
symptoms,
signs and symptoms or who screen positive.
Yeah, but that is only if you say with symptoms, then you're only testing people with symptoms. So that is that's only a proportion for the people who should be tested, because you also want to cover your asymptomatic. So where is the definition of the people who should be evaluated for TB?
I'm going to look at my colleagues to comment on the asymptomatic TB piece. I will say most of our testing recommendations are predicated off of having a symptom screen or testing positive if you're a person living with HIV or otherwise.
Okay. Yeah, so I think the step above, so determining the people who fall into the category of should be tested because they have signs or symptoms, that would be people presenting for passive case detection essentially, or people who screen positive. It would be the people who are recommended for screening. So it would be, our high-risk populations, which are highlighted in the standard here, people living with HIV, contacts, minors, prisoners. And then we go to our conditional recommendations. So broader scale screening among people who have risk factors in health facility settings or populations with a higher prevalence in communities. So if we look in a very high prevalence setting, like above 0.5%, then anybody would be eligible, and we could think about sort of population level screening, which I know some countries with very high prevalence do. In general, I think it's more targeted to specific areas with higher risk. So calculating sort of the portion of the population that should be tested is a bit more of a country-specific factor. But I think the Philippines is one country I know that sort of measures population-level testing. Otherwise, I think it's a little bit more
Tends to be more targeted.
segmented. Yeah.
Sorry, if I can say a few things on that, just based on experience with the countries. Most of the countries, I believe, would use their incidence figures as denominator. Now, the question is how that incidence figures are arrived. And you added that dimension of asymptomatic TB. Now, when conducting the prevalence surveys, there is a subset of populations identified, which are either asymptomatic, and then there are country contextual high-risk groups, which our colleagues have also alluded to. So depending on what those figures tell, and maybe Cicely, you could also add, there is also now an online tool created by WHO of Screen TB, which gives you for each of the subsets of populations in each country where you are likely to find how many cases. So that way, each country can have their own denominators depending on the approach they follow. So it could be if you are indulging in active case finding, which is going out to the population, going to the communities, then those subsets of populations have those figures of those that you need to find. So that way, it's a country specific exercise. So it's not, I would say, a general guidance which can be given to all countries at the same time. But yes, it can be worked out for each country on what their denominator should ideally look like. But then that also depends on resources and their approaches, their strategies. Yeah.
Thank you very much.
I am Grayson from Thailand. Maybe I can answer your question. I have number in my hands. Thailand has 65 million population, and last year we screened them for about 2.5 million, that's about 4%. And believe that this 4% should be the high risk group. In this 4%, we found about 1/3 of notified case of TB. That means that 2/3 of them, we're still waiting for them until they got symptoms and then come to see us for facility, and then we diagnose them. So for total of the notified case, we do the DST about 77% now. Our problem is that we have very high percentage of HR-TB monoresistant of INH, about 9 to 12%. So my question also asked for the WHO is that, is it the time to set for both rifampicin and INH for the first in some country that we have very high rate of HR-TB or not? Yes.
Thank you for the question and for showing the contextual data. It's great to know that that's on hand for Thailand. So WHO does recommend INH resistance testing, and there has been a push in recent years to expand the definition of universal DST from just rifampicin to rifampicin and isoniazid, recognizing that there were more than 1 million estimated cases of isoniazid resistant TB, inclusive of multi-drug resistant TB, but outside of rifampicin resistant TB in many cases. And so you're not alone in that context. I think the focus on rifampicin has traditionally been because it is a driver of regimen change as opposed to isoniazid resistance detection, which could lead to a difference in dosing and may not always lead to a complete change of regimen according to the drug-resistant TB guidelines. However, particularly if you have a setting where you know that you have isoniazid resistance testing, then certainly or isoniazid resistant circulating at that level, it's certainly recommended to build capacity for that and to ensure that there's access as part of your universal DST plan so that you can make sure that those patients, first of all, are receiving appropriate therapy. You'll be able to monitor what those changes in therapy are, along with ideally treatment outcomes whenever you have that information that you can link within your information systems in a country. But you can also be able to monitor what that resistance may be additionally linked to over time, particularly as new regimens are introduced.
Thank you very much, Patricia. So I would like to request all countries over the day, if you have 5 minutes spare, maybe to have a good look at this, at your own risk groups. How many people are really at risk, should be screened for TB? So maybe by the end of the day, we will do a show of hands and we will hear from you how many million people should be tested for TB in the first place. Yeah, so that's for over the day. Now I would like to hand back to Patricia for your next presentation. Thank you very much.
No, it's an excellent point. I mean, I think, you know, the reporting has highlighted that this getting at this presumptive TB number is very, very challenging, and how that's defined in your different settings will vary slightly according to the definition. So thank you, Agnes. Okay. Could we have the second presentation, please? And thank you for all the active participation. Please keep it going. Keep up the questions and all the comments. Okay. So now we've set the scene. We've talked about our objectives, reviewed the agenda, and we've talked through a little bit of where we are with testing. And now we're going to move into the diagnostic testing section. So this is initial diagnosis. The updates I'm going to cover today were published in a rapid communication that was released in August of last year. But they are being incorporated fully now with all of the evidence tables into the forthcoming copies of the WHO consolidated guidelines on TB diagnosis and the operational handbook. And so we're going to look at these in a little bit more detail with some of the evidence behind them today. Okay, so I'm going to use that as an opportunity to tell you a little bit about the updates that are coming and some of the structural changes along with the policy updates that are coming in the new consolidated guidelines and operational handbook on TB diagnosis. So we have 3 categories of updates coming for the 2025 documents, again, planned for publication in Q2 this year. These are structural updates, new testing classes and product endorsements, and testing strategy updates. So for the structural updates, we started this yesterday. Actually, I mentioned that we're consolidating now and combining TB infection and TB diagnosis and drug resistance testing into the same document. So that will all be in the same guidelines. Those will be in the same operational handbook. In addition, now, based on actually feedback from member states, we are incorporating the complete list of recommendations at the top of the guidelines. So you don't have to kind of search through each section and each population or test type anymore. There will be the full list right at the top of the guidelines. And there will be a summary of changes in this version that we plan to carry forward. So when each new version is released, you'll see what has changed between the previous version. We've also added a chapter to the consolidated guidelines this year on diagnostic class determination and WHO pre-qualification as relatively new, and we felt it could use some streamlining and a bit of clarification. And I'm going to cover those topics today to provide you with those updates in advance of document release. And then, of course, we've revised the diagnostic algorithms the way we do in each version to incorporate the latest policy recommendations. In the second category here, we have new testing classes and product endorsements. So we are specifically including the 2 new classes of low complexity nucleic acid amplification tests for detection of drug resistance. This includes both automated and manual, which we'll talk about. The 2 new interferon gamma release assays that we talked about yesterday, and 1 updated targeted next generation sequencing solution for the detection of drug resistant TB that we'll talk about later this afternoon. So all of this will be consolidated into the forthcoming guidelines. And then for a testing strategy update, we will include new recommendations on the concurrent testing of multiple sample types for children and people living with HIV. So in this specific presentation, I'm going to cover the 2 new classes of low complexity nucleic acid amplification tests and the concurrent testing strategy. And then we'll get to drug resistance testing a little bit later in the day. Okay, so WHO has moved away in recent years from product-specific endorsements. So we came from a time where we had smear microscopy and we had culture. And then for some years, we had Cepheid's expert products. And so we were doing these product-specific recommendations and reviews because there was a low number of products. But in good news, we've seen an expansion of products and of manufacturer interest in product development for the tuberculosis pipeline and for tuberculosis testing. And so what we've done is we're moving away from product-specific endorsements and now grouping products into classes of diagnostics, as is done for example, HIV, if you have experience working in that field. And so these classes now include diagnostic testing technologies that share these characteristics. And what you will see in this version of the guidelines is that each class has a table that includes its characteristics that are unique to that specific class. So if there's a new technology coming, this is what it's evaluated against. So the products are evaluated for their purpose of use, for whether they're for drug-resistant TB testing, detection of TB infection, for example, their principle of action. So are they biomarker-based? Are they nucleic acid amplification test-based? Their infrastructure and human resource requirements, as far as how complex they are and what types of skilled individuals might be necessary to do the testing, complexity of the testing procedure, and the associated instrumentation. So for those that are familiar with past recommendations, this would be, for example, the moderate complexity tests versus the high complexity tests that were previously included in the latest guidelines, the reporting method, so whether it's automated or manual, and the setting of use. Specifically, whether that setting is reference peripheral laboratory, whether it's a low complexity basic infrastructure laboratory, like our gene experts or MalBio TrueNats, for example, or whether it's near point of care or point of care tests. The only point of care test currently available for TB is the urine-based lateral flow LAM test for detection of TB among persons living with HIV. At the moment, we do not have any near point of care tests. So these would be instrument-based tests that don't necessarily require laboratory infrastructure, may require some level of instrumentation, but would not be quite as infrastructure heavy, let's say, as the gene expert or the MalBio. However, there are some in the pipeline. And again, on day 4, we'll be talking through market shaping and considerations for the development and the uptake and introduction of those tests. Okay, so what does this mean? So WHO now has these 4 categories, and you'll see this class-based table at the top of the guidelines when it comes out that stratifies the classes by the initial test for detection of TB with drug resistance, initial test for detection of TB without drug resistance, follow-on tests for detection of drug resistance, and tests for detection of TB infection, again, signaling that we've combined those categories. And this is really just kind of following the phasing of testing that would traditionally happen for a patient. When a new technology now comes to WHO, let's say a new test or a new product has been developed, it comes to our global program on tuberculosis and lung disease, and we do an evaluation. We look over the characteristics in the class determination table and determine, does it belong to a class that already exists, or is it something new? If it is a new class, then it goes through evidence review, systematic reviews, following the standardized grade process for guideline development group determination, and it will go for WHO pre-qualification assessment. If it falls within an existing class, then it will be assessed by PQ if the process is already available. So let's say a new GeneXpert-like product comes along. It comes to us and we say, yes, this is a low complexity test. It can go directly to pre-qualification. We don't need to assess the evidence for it. It goes directly forward for pre-qualification. However, if a pre-qualification process is not yet available, then it goes through evidence review that's done by our technical advisory group on TB laboratory strengthening and diagnostics. The reason that I'm going through this is because yesterday we talked about technical advisory group reviews of the new IGRAs, and that's because they're within the IGRA class. So they are within class and we flew through this pathway. Today, we are going down this first in-class technology assessment pathway. But we're doing that with a couple of technologies that have already been recommended. So the next slide or two should not be new to anyone. This should look very familiar. It was our effort to go back and look at the products, the GeneXpert, for example, Expert MTB RIF and Ultra, the MalBio products, and the Icon Chemical TB lamp product, and place them within classes, do class determinations for what that looks like. Okay, so these are all of the classes with all of the products. We now have 9 classes, and look at all these products. This is great news for TB. We understand that it does increase the complexity of test selection and placement for programs, but options should also provide for more customization of your testing algorithms and placement. Okay, so the new TB testing classes, without further ado, we have the low complexity automated nucleic acid amplification class, or the LC automated NATs, sometimes called LAC-NATs by those that want to shorten the acronym because we understand that it's a long acronym. This includes the Expert MTB RIF Ultra test, MTB RIF as well, while it remains available on the global market, and the TrueNat MTB Plus with MTB RIF DX chips. These are instrument-based tests. These are very well familiar to many of you, right? So you need the instruments. And this is, or was, the class definition table. Here, if I can get it back up. Seems to be moving backwards. The other direction, there you go. I think. Did it do it? Did. There we go. Thank you. So you can see that this class is for the detection of TB and rifampicin resistance. It has either no or only one pipetting step. Most reagents are enclosed inside a disposable closed container. They're automated result reporting, and it has a basic laboratory setting of use. So this will be the structure that all of the classes will follow, this type of assessment and very kind of quick, brief descriptions of what their characteristics are. Trying to work towards performance. Here we go. Okay, so these are the recommendations for the classes. There are no major surprises here. These tests are still recommended for adults and adolescents with signs or symptoms or who screen positive, for Agnes's point, for pulmonary TB. Both of the technologies assessed are recommended for this using respiratory samples for the detection of TB. These are also recommended in people with bacteriologically confirmed TB for detection of rifampicin resistance. However, data was only available on the GeneXpert-based or Ultra product for detection of TB among patients with TB meningitis and among those with extrapulmonary TB or with presumptive status. And you can see the samples that are included here. These will be listed along with updated performance information in the operational handbook. So no new surprises. We did do an updated systematic review of performance across now a wide amount of data for these tests. And so the performance characteristics have also been updated, but look very similar to previous guidelines. In addition to the low complexity automated class, we now have the low complexity manual class. So for those that may be familiar with the LoopAmp MTBC detection kit or the TB lamp assay, it requires basic equipment, a heat block and a UV lamp in order to perform. It does require stable power. It can be implemented at the lowest levels of the laboratory network. This is what the read looks like. And this is for detection of TB. This assay does not include drug resistance targets, so it can't be used for rifampicin resistance testing. Again, its reagents, its skills are basically very similar to the low complexity automated class, but it includes multiple pipetting steps, which makes it more manual. It's not as automated as the other assays. And the type of result reporting can be automated or manual, but many of the sites that are using it are using a manual by eye visual read. And so because of those manual components, a slight increase in complexity, although not above low complexity in the laboratory setting, this separated it from the other class of automated assays. We have a single recommendation for the use of this technology that's in adults and adolescents with signs and symptoms or who screen positive for pulmonary TB using respiratory samples to detect TB. The sensitivity is a little bit lower than the other technologies and the low complexity automated nucleic acid amplification class. However, it was still recommended because it can improve access in settings that need lower infrastructure requirements for the heat block and the UV lamp compared to the continuous power needed for the 2 hours for gene expert testing, for example. It does apply to all people living with HIV, and it was extrapolated to children. However, in settings where the concurrent testing that we're going to talk about can be done, that is the preferred strategy for those populations. Data was not available on the use of pediatric stool samples. It was very limited. I think we had 1 or 2 studies, and there were no data on the use of nasopharyngeal aspirates in order to recommend this technology for detection of TB among pediatric samples or pediatric patients. So that's why the pediatric samples for respiratory are limited to sputum and gastric aspirate. And they do not provide, of course, rifampicin resistance results. So any positive test needs to be referred for follow-on drug resistance testing. Okay, so those are the classes of technologies, again, very familiar to many of you in the room. The new piece to this that we're going to spend a little bit of time in the discussion session talking about, and that you'll see reflected in your Excel sheets for the working session later in the day, is really around this concurrent testing piece. Okay, so concurrent testing, what is it? Well, this is the #1 question, I think, since the statement came out that we get. And so I just want to start out by making sure we have a shared understanding. This is when multiple samples are taken from the same patient, ideally at the same time whenever possible, and multiple tests are conducted, again, as close in time as possible. This can be done using 1 or more tests. A positive result on any of the samples and tests is considered a positive result for the combination. However, the inability to collect a second or a third specimen or the unavailability of a second test type should not delay testing. So this recommendation and the series that follow are not intended to delay or serve as a barrier to testing. It's intended to improve patient access. And so why do it? There are significant burdens of TB, we know, in persons living with HIV and in children. And we know that diagnostic testing among these populations is really challenging. They have possibacillary samples. Oftentimes the sensitivity is low. It challenges the sensitivity and the limit of detection of the test that we use. And multiple sample types can serve to improve overall diagnostic yield, can simplify diagnostic processes through the introduction and routine recommended use of easy to collect sample types, and can potentially shorten the patient journey. So this is a little bit of a busy table, but I'm going to walk you through it. So for concurrent testing recommendations, we have 3. The first population is shown on the top. Adults and adolescents with signs or symptoms of TB that screen positive TB are seriously ill or have advanced HIV disease. In this case, the recommendation is to use both low complexity automated nucleic acid amplification testing on a respiratory sample and also to do lateral flow LAM on urine. This does supersede the previous lateral flow LAM recommendations. So there is no more disaggregation of CD4 cell count availability or whether the person living with HIV is an inpatient or an outpatient. While that performance data will be available in the guidelines, this simplifies, ideally, the lateral flow LAM access pathway for persons living with HIV. In children, there's low complexity automated NAT. So again, the ultra in this case, and the low complexity automated NAT on stool. So now you're taking a sputum specimen, if it's available, or the stool specimen, if it's available, ideally, both samples are collected and then they are tested using ultra. The children living with HIV builds on the recommendation, the concurrent testing recommendation for children, by adding on LF-LAM and urine. So now if you're a pediatric patient, you would get a respiratory sample collected in a stool. If you're pediatric and HIV positive, then we also collect a urine. In practice, this means if you're HIV positive, urine is collected and you get your lateral flow LAM. Ideally, sputum is collected at the same time. But if the LF-LAM is positive, it's a positive result for the combination. However, we know LF-LAM doesn't provide a drug resistance result. So if that patient can provide the sputum specimen, this is why we're still recommending collection of the respiratory sample so that you can get your drug resistance test result via ultra. There was no or limited data for this concurrent testing strategy for TrueNat MTB+. And so that's why the recommendation is currently for the Expert MTB RIF Ultra technology. Oh, sorry. I should talk about the performance. So the reason, one of the main reasons that this is recommended is because you see an increase in the incremental diagnostic yield with this strategy. So if you do one test, in this case, the reference comparator is only a respiratory sample, you would get, as a comparator, 68% sensitivity. But by collecting the urine among adults and adolescents, you increase that to 77.5%. This is even higher when you compare against a composite reference standard that considers clinical diagnosis. Then you can get upwards of 16% increase in sensitivity for detection among this population. However, you do see a concurrent decrease in specificity. And so this needs to be taken into account, particularly in lower prevalent settings for HIV. For children, you see an incremental increase in sensitivity of 7.1% with a moderate, small to moderate loss of specificity. And for children living with HIV, a similar increase of about 7% in sensitivity for detection. Okay, and this change is now reflected in the revised algorithms in the operational handbook this time around. So when the new handbook comes out, instead of having your algorithm 1, which was molecular testing and how to flow through your molecular testing algorithm, that has now been updated to where it has a patient stratification at the top. So the first box you have here is the person presumed to have TB. You then determine HIV status. If, let's go this way, let's say they're HIV positive, then they fall within the concurrent testing box. If they're HIV positive, you determine whether they are adult and adolescent or a child. And the algorithm now tells you how many samples to collect for which test types. If they are HIV negative or their status is unknown, then again, are they an adult or adolescent or are they pediatric? And that again guides you to how many samples for which test types should be done. Then you still have the familiar pathways at the bottom here for what to do and what decisions should be made to guide interpretation of the test result based on that result. But what you have now is LF-LAM incorporated into the bottom of these pathways along with your molecular test. So there are no more standalone algorithms for lateral flow LAM. The algorithm 2, A, B, C that you're familiar with from the last guidelines, you will not see in this version. Instead, this is now a combination approach because all LF-LAM testing is recommended to be done concurrently with a molecular test. And because of that, the interpretation pathways that are down here will be updated to consider positivity and use of both test results through each of the pathways. Okay, lastly, just a comment. I know I showed the pathways at the top and assessment, stratification by WHO. All technologies that go through and are assessed for recommendation end in pre-qualification at some point in time. This process is still under development for many of our classes, and so it's not yet available. However, I did want to highlight that specifically for these nucleic acid amplification tests and for the LF-LAM test, pre-qualification processes are either available in the case of the nucleic acid amplification test or becoming available for the urine lateral flow LAM. If at any point in time you'd like to check to see who has submitted of the nucleic acid amplification test for pre-qualification, whether they are pre-qualified, how close they are, this is publicly available on our pre-qualification website, which is linked on the slides. Currently, the Expert MTB RIF Ultra was the first TB test to receive pre-qualification. The XCR test is also in the process, along with 6 other additional nucleic acid amplification tests. And again, once the guidance is released, it will be available on the WHO TB knowledge sharing platform For any of the documents related to prior recommendations, of course, the latest versions are there and can be accessed with the QR code. Thank you.
Thank you very much, Patricia. Quite a lot to take in, I think. Also many complexities. Are there any questions?
Hi, thank you. I'm Sharon Ann Lynch with the Diagnostics Equity Consortium. So I have two questions. Well, one comment. The concurrent testing guidelines is so welcome, long overdue, and thank goodness. But don't you think that CD4 testing should be bundled as part of the first for all people living with HIV that have TB symptoms? And why? Because so often CD4 is used as a screen for AHD, and AHD is not, advanced HIV disease is not diagnosed due to the lack of CD4, with so many countries dropping CD4 at baseline in order to just focus on viral load. So that's one question. The other question is, don't you think there needs to be a separate track and a bit of nuance, particularly for inpatients? So those with TB signs or symptoms, those that are living with HIV, that should therefore receive a TB LAM test, since WHO recommends TB LAM for all HIV positive inpatients. Thank you.
Sure, both excellent questions, Sharon Ann. So as far as CD4 availability, I think that is an HIV treatment program and guidance question primarily. I do think that CD4 remains essential. For those who may not know me, in my previous life, I did tuberculosis and TB HIV testing before joining WHO. I think that CD4 does remain essential for clinical care of patients and for early staging and identification of advanced HIV disease. I do think also that there are performance differences for our tests among those populations that are stratified in the guidelines. And so it's one of the reasons that it's still included in the eligibility criteria of the population right up front. So positive for signs and symptoms, screen positive, severely ill, or advanced HIV disease. And the primary way to detect that is with CD4 testing. So it still is important, but it shouldn't serve as a barrier. Lack of CD4 access, we don't want to serve as a barrier, right, to LFLAM. And so it's kind of straddling that line in between, I think. Now, just to clarify that for this new guideline and the recommendation for concurrent testing, particularly for lateral flow LAM use, is for in and outpatient. So there's no stratification here. So this is for all persons living with HIV. This is the concurrent testing strategy. Certainly, the systematic review evidence and plenty of at least 2 of the clinical trials that underlaid the evidence review showed incredible benefits for inpatients as far as mortality reduction, for example, and certainly time to diagnosis. So I think outcomes differ between those 2 populations, but they're all eligible for LFLAM testing. Now, there's no more stratification of setting.
Thank you.
Thank you. Very nice presentation from the diagnostics. I have some questions like Expert Ultra. After introduction of Expert Ultra, we are facing lots of problem in our program. First of all, the trace report, it's very difficult for the program persons to decide whether this is the positive or a negative. And second, if the test report is like GeneXpert, they detected very low burden of the bacilli. At that time, the RR, there is a we can see the RR, that is the false RR. And I have seen in our centers around 80% RR false if there is a very low bacilli load. So at that time, we are even not very experts or deciding whether this is the false or true. Sometimes we check the reference values given by the CPID, like every probe, there is the melting point, and melting point, we check whether this is a false or a true, whether how much standard deviations is from the false or true. Normally, we take 1 or 2 standard deviations from the reference as a false or true. So how your report says about this false RR in the Expert Ultra? How many percentage is the false RR in the expert ultra where the baseline load is low and very low?
Yeah, it's a great question. And so far, the published studies have varied quite a bit on this, depending on setting and depending on the type of evaluation and follow-up of investigation and how false rifampicin resistance was determined. In some settings, so let me just start by saying with expert MTB RIF, once you got to a very low quantification, certainly false positive RIF resistance results were acknowledged in various publications. However, it was around 1 to 5% of overall testing, typically less than 2% in most settings. And there is, I believe, a reference for that in the footnotes of our new guidelines as well in the interpretation pathway. For ultra, there have been varying reports. And I think what tends to happen is when you get to very low, as you're saying, there can be this shift, but the probes are so much harder to interpret because you don't see the melt curves the same way. You see that whole range of probes. So I think it's a programmatic question of investigating how often is this systematically happening? How much is it geographically happening? Are you seeing back-to-back results at that level with no other factors involved? And we haven't been able to pin down any specific data sets that point it back to the test itself having a problem that has done that type of differential. I would say if it's something that you're seeing in your program in particular, as you're saying now, then it's something we can certainly follow up on and talk about as to whether or not those follow-up investigations have been done to look at the other factors that could be confounding in the background. And always report these to the manufacturer is the next thing I would say for them to be able to respond.
Sometimes it's resistant and sometimes it is sensitive. If you repeat the test, again, it will come the sensitive. If you repeat again, it is the RR. So that's very difficult to interpret the report of the expert.
This is, at the moment, we don't recommend repeat testing, particularly with those low quantities, because there's a low quantity of bacteria and you may have a mixed population, you may get a variability in the low curves. And so that it can be very tricky to interpret.
So what are your suggestions? We take it as a RR or a DS, drug sensitive or rifampicin resistant.
I mean, according to the guidelines, if you get that low quantification rifampicin resistant result, you take it as rifampicin resistant, and then you evaluate it in the context of your program and the clinical picture for what you expect.
Thank you.
I think we have a question online, so I'll, Mansa, if you could open that up. And I'd like to welcome our Myanmar colleagues who have joined us online today.
Yes, yeah. I want to know that for the urinary lamp test, as we all know that the urinary lamp is only used for the people living with HIV patients.
Can you unmute yourself? Who's online to ask your question?
For the urinary lamp, urinary lamp is only used for the people living with HIV, but in our country, in Myanmar,
the person online, if you can just wait a minute, we are dealing with some technical issues to make sure we can hear you, but your question is important. In the meantime, while we're just dealing with these technical issues, it would be great for people in the room after this question. I will be asking who's doing the concurrent testing, both for pediatric TB as well as for PL-HIV. And then also we will then have an opportunity to find out your experiences.
Yes, can I ask the questions? Can I ask the questions? The one who said.
Thanks for your patience, person online.
Are there any other questions? If not, then I have a question. Oh.
Hi, thank you very much. Puneet Dewan from the Gates Foundation. I wanted, while we're waiting for our colleague online, who I hope to hear from, I wanted to ask about the differentiation between the manual low complexity automated NAT and the manual low complexity NAT and automated low complexity NAT.
Mhm.
If you could just expand on the sort of why that differentiation was felt to be useful and needed to be made as a class, and what it might imply for, I guess, future assays and simplified PCRs and other approaches which might fit in, because what practically, I guess, changes for the programs with that differentiation, and why? Just if you could just explain the rationale for making that split, so we can at least perhaps understand how it's applied. Thank you.
Sure, no problem. So the difference between the automated versus manual. So the manual was intentionally separated through discussion with the guideline development group and with the technical advisory group, because largely the procedure and the result reporting are so much more manual and require more steps and hands-on time than those in the automated testing class. So one is, a 1 or 2 step, up to a couple of pipetting, automated kind of closed sealed container goes into an automated instrument. It tells you what the overall result is, provides you with the melting curves ideally, or the probe information in order to interpret that. The other is a manual multi-step up to 10 steps of transferring material across different, the heat block and manipulating the tube. It has an additional sample treatment step in at least one version of the protocol. And it typically is read by eye, which relies on trained and then retrained and certified testers in order to look at it. And so based on kind of the considerations for the complexity, that's why it was separated out. Whereas if they were all together in one class at the time, the determination was made that that would signify that they were of a similar type of test as in terms of complexity. But because the complexity and the type of reporting are specified in the class determination, it was felt to be useful to look at the variability between those tests. Now, I will say, when we start to talk about near point of care technologies and others that would be placed at lower levels, the kind of working assumption at the moment for WHO is that these would not necessarily vary so much in the number of steps required across everything. You wouldn't expect a near point of care or point of care test that has 10 to 15 steps to complete it necessarily. And so the thinking is that because the near point of care class has already been defined by the target product profile, that there may not be that differentiation at that level. But for laboratory testing, there was.
Can we see if our colleague online can ask a question?
Yes, thank you. For allowing to make a question. My question is, urinary lamp is used only for the people living with HIV. But in my country, Myanmar, there were some areas doing the urinary
Maybe if
lamp
we're having
as
challenges, we may need to type the question. Okay, we'll have another question where we continue to work on our IT.
So this will probably be covered in the workshopping sections, but which countries do we know of that are ready, willing, and able to adopt concurrent testing as you've presented it? Do we know already?
So I think we have a good idea of the number of countries because of work reporting done to WHO and because of partner work as well, the Step Up report for TB and others that look at policies in place of how many countries are current doing lateral flow LAM and molecular testing for PLHIV and how many are doing potentially stool testing or easy child-friendly specimen collection. And so I think we will use that as a proxy. But certainly it's a wide number. It is region dependent. However, there are variabilities across countries, even in the high burden set.
So I'm trying to be very diplomatic by not specifically asking countries in the room, but I so want to ask countries in the room.
That's coming.
Okay, I thought so.
Stay tuned.
I'll go back to my seat.
No, it was great. You set up Grania.
Yes, I think so. I hope the IT, if you could just interrupt us if we are able to get the online to working. But I think, as I warned you, and as Sharon Ann has also reminded us, this is the question to those in the room. Is any program implementing, updated their policies and started to implement the concurrent testing? Put your hand up. Okay, for those online, we don't have any hands up. So but recognizing that this is a relatively new policy and it is a rapid guideline, I've forgotten the right term for it, but it's been incorporated into the fuller guideline. How many countries are considering the necessary steps for the policy change and implementation of, and I'll break it down into two groups, concurrent testing in children? Excellent. We've got one country that's considering it. Great. And I think I would love to hear your thoughts about how that's going, challenges, and sort of your approaches and timelines. Thank you.
Thank you. In Papua New Guinea, for the children, we've already started the stool testing. And the stool testing we've piloted last year in one of the capital, Port Moresby General Hospital. And this year we are looking at rolling out through the country. So this is done by the program and not partners. So with the program, the NTP program is rolling that out to the country. Yes, we have a lot of challenges. With the testing that we did last year for the stool, we had a 10% positivity rate for the stool. So which is something that is quite good for us. It's going to be a guidance for us because children is quite difficult for us to have a diagnosis on. So that's something. This year also in 2025, we are planning to bring the LFLM for the HIV patients for us. So we have an algorithm. In the country, we have around 75 gene expert sites. We have 136 microscopy sites. We are working and trying to strengthen the referral of our samples. Yes, we agree that our challenges are there because of the geographical challenges we have. We are trying our best as a program to see how we can work with our political leaders in the provincial, in the provinces to strengthen the referral pathway. Last year, we were privileged to have a DNO study for the first time in the country, which was supported by 3 donors. That was Global Fund, the FIND, and USAID. So we did DNO for the whole country, and now we have a report that we see the challenges that are faced in each province. Each province is in our country, we have different challenges. It's not the same challenge in all the provinces. So that's how we are looking at things to see how we could strengthen each province by province, whichever the commitment from the provincial leaders are coming to play. So that's something that we are doing, and I'm grateful to see all these algorithms and new guidelines and all that. And that's something that we will look into incorporating in our guidelines. We have algorithms in place, and we have 6 categories of risk categories that we do on the microscopy sites. We have only 75 gene experts because of the infrastructure and those limitations. So we really need to strengthen our referral now. But in the country, we've already adapted all the WHO recommended tools in the country. We have only one PC3 laboratory in country which does the cultures. However, it's not functioning at the moment. Global Fund has assisted us to maintain that, and we should hopefully start in the quarter, this second quarter. And despite of that, we've rolled out all our MDR for the XDR cartridge. So we have XDR testing in all the provinces, and we are just looking at strengthening the referral of samples to those testing sites. And so For us in country, we are hopeful that we will be covering a DST throughout the nation. So thank you.
Thank you very much for this overview of what P&G is doing to strengthen their laboratory capacity. And you started mentioning that you are already embracing the stool testing. The question also was about the concurrent testing. So maybe I would like to give an opportunity for each of the countries to say whether indeed you are doing stool testing. That's the first question. And secondly, are you considering to do both? And meaning that you have to have 2 cartridges for each and every child, but basically to turn it into practical sense, and an lung test for people with known to have HIV. So can I start here to ask Cambodia?
In Cambodia, we do not have we do the stool testing for the children, but we do not have do the gene expert for them, because you know the first priority for the testing first is gene expert. As far as we can collect the sample from the from children from the sputum, so we do the gene expert. If the sputum not available, not able to collect it, and we use the stool. So no, there are 2 from Cambodia right now.
Okay, thank you very much. So Cambodia is doing 1 test. Yeah.
Yeah, for Nepal, definitely everybody wants to diagnose as soon as possible, do concrete testing, but it's difficult for our budgets. It's not enough to have concurrent testings of or many tests together. But we are doing patient by patient. Sometimes if there is negative, then only we consider the other. That is the patient approach, not the programmatic approach. And I think in future, even within a year or 2 years, we have no such a plan of having a concurrent testings on the same patient.
Could I ask a follow-up question? Is there an order? If you do one and it's negative, what do you collect? Do you do the stool first, or do you do the?
We do the respiratory sample if possible first, or a gastric lavage, and then if it is negative, then go for the stool test.
Okay.
Next country, Vietnam.
Yeah, in Vietnam, we are also using the expert, apply expert in stool for children for diagnosis TB in children, and this is similar. This is because of the limited resources, and the positive rate in the expert in the children is very low. It's around about 1-2%. Is it being cost effective is around the number of the negative is very big. So we consider using only 1 test for diagnosis. Yeah.
I'm now going to be standing in front of this table.
For Thailand, in children, we also use 1-by-1 test. We'll start with expert first. If negative, then maybe we consider stool later, or maybe shift to bronchial wash.
Okay. And anyone from Indonesia program like to give their reflections? It's a hot mic. I promise it won't burn.
Yeah. For Indonesia, we already have in our guidelines for testing, but it's only one-on-one. So for stools, we already have it, but it's not kind of the first recommendation for testing in children. However, we haven't had the concurrent testing yet in Indonesia.
You can't avoid me. So move from this table.
In Bangladesh, we are practicing stool test for the children in practicing all over the country. And we also use pass urine for the gene expert machines. But in Bangladesh, we are not practicing the parallel use of low complexity automated nucleic acid amplification test in Bangladesh. I think after the information, Bangladesh will introduce this type of test in future. Now it is not practicing in Bangladesh. Thank you.
Now, have we got any countries who haven't? Mongolia?
Mongolia.
Yeah. Good morning. Our national TB guideline included these methods and policy. Then our laboratory doctors now ongoing one research. This is trying to collect children stool, then diagnosing phlegm. Phlegm. Yeah, this research ongoing. Maybe second quarter of this year we will report the result.
Can I ask a follow-up question about that? The research that's ongoing, what is the aim of the research? Is it for the method or to look at performance of stool, or what is the aim, the overall objective?
Mm-hmm. This research aim is a compared gene expert and LAM. So, yeah, we will share the correct protocol and method after during.
Okay, I think they're fantastic.
Yes, good morning. Actually, I just would like to go back to the you asked the screening population is how much, but it's difficult to say because it allows that we don't have such kind of systematic screening. So we just based to that report from expert size is we can say it's less than 1% of the population, but in NSP that we would like to have like a 1% of population, but I never reached the target. I come back to the children for a student test is of course we just start in this year, but we have no any case file. That's is thank you.
So thank you very much. Maybe you would like to comment on that, and then otherwise we also have a question from from Myanmar.
The Philippines here would like.
Yes, I'm not from the NTP, but we're working closely with the NTP. So Philippines is starting to embark on stool expert. Last week there was a training by the NTRL to the trainers in the region, and there's also a draft policy already for the lab side.
Thank you. And unfortunately, we haven't been able to allow our Myanmar colleagues to ask their questions themselves, but they very kindly type them in the chat. So Mamansa will ask the questions.
So, and is the specificity and sensitivity of urine LAM reflected only on people living with HIV? So, because in Myanmar, urine LAM is used for diagnosing people without HIV.
So yes, our global data and the recommendation is for use of urine LAM only among people living with HIV. And that was a decision that was initially made when the policy and when lateral flow LAM was first recommended based on performance differences in HIV positive versus HIV negative individuals, and was reconfirmed with this latest performance review. It would be great to connect with Myanmar on those results. While it's not in alignment with our current global guidelines, we are aware that there's several lateral flow LAM new tests that are in the pipeline that promise or are looking to achieve increased performance in both HIV positive and negative individuals. But it is really important if they're being used among PLH or HIV negative individuals, that the interpretation of the results and the expected performance is stratified accordingly.
Great, thank you. Are there any other questions on the concurrent testing? And thank you, countries, for sharing your reflections on this.
Can I make just a couple of comments based on, thank you so much for the inputs. This is incredibly valuable and helpful for us. If there are other operational or feasibility considerations or concerns that you have, please feel free to raise them. I would say a couple of comments that were addressed. So the sensitivity of stool alone is going to be lower than sputum by all evidence reviews done to date. So the fact that stool testing is done and maybe they're not often positive or not as positive is expected. And I think that gets to my second point, which is training, particularly of healthcare workers and the clinical side of things on what to expect, what the advantages are for use of stool as a child-friendly specimen, and how to interpret those results, particularly in the context of concurrent testing, are incredibly important. We saw this with lateral flow lamb. We saw it with the introduction of stool. And it came out as a really important piece of the feasibility assessment that we did through qualitative evidence of the sites that had some experience with concurrent testing, particularly between the healthcare workers and the clinicians that really wanted to understand the rationale for why you would collect two specimens if you can get sputum, for example. So really having that very clear can be very useful to facilitate uptake and implementation.
And can you then maybe say what the consideration was of the guideline committee, also knowing that there's cost involved and there's logistics involved and all kind of things. So what was the consideration of the committee to recommend concurrent testing instead of consecutive, depending on which sample is best available?
Sure, it was a positive recommendation. So it was recommended. It was conditional and with varying degrees of evidence and noting feasibility. The cost effectiveness data did show that it was moderately cost effective when you consider disability life years adjusted and the other modeling estimates that were done. However, the affordability challenge was noted by the group and is noted for monitoring and implementation considerations for sure. We recognize that there is an affordability piece along with the cost effective piece. We would all love to find every TB patient, but that was a recognized concern. So it is listed under considerations for implementation and also for monitoring and evaluation in the latest guidelines. However, the recommendation is positive, given particularly that the guideline development group felt that the improvement in access and overall diagnostic yield among children in particular as a difficult to diagnose population outweighed. So those benefits outweighed the risks at this point in time. My last comment on this would be to acknowledge that testing, particularly for pediatrics, is part of a more clinical, holistic approach to pediatrics. So this is one piece I'm looking at my pediatric colleagues in the room. I would be remiss if I didn't acknowledge this. Our tests are only so good in pediatrics, even with a concurrent strategy. So please do consider chest X-ray and the clinical evaluation pieces that are needed in addition to the diagnostics.
Thank you very much, Patricia. And thank you very much, everyone, for contributing your experience and the situations in your country and your ideas. I think overall, looking at the themes that came up today, is the point of, I think, very valuable suggestion from the treatment advisory group to maybe add a benchmark on the free of chargeness of the available diagnostics. I think that's a very important topic. I would like to start with that one. Then I think we also touched upon the difficulty of deciding what your denominator is if you're saying the number of people that should be tested for TB. I think yeah, it might be good maybe if there would be some clear guidance on how we calculate this across the world. Then you can start comparing. Definition is always useful. So that is the second point. Then I think we had quite some country input on what the current implementation is of the concurrent testing, which focused mostly on concurrent stool or respiratory samples for the WHO recommended rapid molecular diagnostics, specifically expert because of the validation of stool for expert. And we see that that concurrent testing is not really established yet. Mostly established is consecutive testing. If I go here, so either stool first, and if stool doesn't yield, a respiratory sample, or the other way around. If a respiratory sample is available, and then you follow up with stool. I think that was what we did not tease out yet, but I think we will do that in the afternoon during the implementation planning, is about the implementation of the LF-LAN. Yeah. So thank you very much, Patricia. I know you're the only speaker here, but I do not think that we regret that. You're a very good speaker, and you're very good.
I'm doing my best. I'll try to act out the next portion.
Thank you. So now it's time for a coffee break. So if we could all be back at 11:15, and we're going to targeted next gen sequencing after the coffee break. So another really new and exciting topic. So please be back promptly at 11:15. And for those online, it's half an hour. So for wherever you are, we'll see you again in half an hour's time. Thank you very much, everybody. And thank you, Patricia. I like walking.
Hello. 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 Yeah. Hello. 1, 2, 3. Online can speak. People online, can one of you speak? We are just regulating the Zoom link.
Hello, can you hear me okay?
Can you hear me? Hi, Mansa. I can hear you.
Oh, okay. Then yeah, Christine and Dennis, we can hear you now.
Okay.
Yeah, we could hear the other speaker before, huh? We could hear
Okay,
Mint
thank you very much.
already.
Now we can hear you, so and you'll have the ability to speak.
Okay, thank you. Good luck.
How do you want to?
then maybe Dr. and then to yeah. Yeah. And then yeah. Yeah. Share, see. Good. Just because interesting. My
So, dear colleagues, after some refreshment, we are back in the game. I would like to have one question for all of the countries. That's what we have not yet. Hello? Hello? Hello, dear colleagues. I think we all had a good rest and some coffee or tea. So we can go back to our work. I would like to have one question before we continue with the next presentation of our favorite presenter today. I see that Vinit has, oh no. Anyway, so I would like to have one question to all countries, very quick, a show of hands. I would like to know if in your country, the use of LLM is already as per WHO recommendations. So the use of LLM for people living with HIV. Is that already happening? Cambodia, yes. Nepal, no. Laos, do you have that? I think you mentioned it's within the HIV program. Yeah. Okay, and Indonesia? Planned by the NTP or by the HIV program? HIV program. NTP. Okay, PNG?
Into the country. So there's something that we did not procure the kits yet. And that's something that we'll be procuring this year, and then we can bring it into the country and start. So that's already, we've done some work on that, and we will soon implement in country. Thanks.
Okay, thank you very much. So there's some variability, but by and large, it's being implemented. Some countries still planning and starting out. Thank you very much. Patricia, take it away.
Thank you, Agnes, and thank you for the feedback. Okay, coming back from coffee break. Hopefully everyone had a chance to stretch, to get some coffee, some refreshments, some snacks, raise the blood sugar a little bit before we have to sit down again and discuss the next diagnostics topic. But it's been really great discussing with you and learning what's happening in each of your countries. And so thank you, and please keep the inputs coming. So now, after the coffee break, we will be shifting from initial detection of TB to drug resistance testing. And I'm very specifically in today's presentation going to focus on next generation sequencing. Having said that, before I begin with the slides, please note that the other classes of drug resistance tests are still recommended, and they are still have a very valuable place in the network, particularly the decentralizable tests like the Expert MTB XDR that can give you the additional INH and the rifampicin resistance test, and the other moderate complexity nucleic acid amplification tests. This would be the Roche Cobas and the Abbott real times that can give an MDR result as well. So please keep those in mind. Even though we're focusing on sequencing, it is not the ultimate one size fits all solution for networks. Okay. the presentation outline, just to walk you through, because I do not want to assume that everyone is a sequencing expert in the room, we will talk a little bit about what sequencing is and what we mean when we say next generation sequencing before we get into the latest recommendations. Then we'll talk about the recent and forthcoming policy on targeted next generation sequencing from WHO for detection of drug-resistant TB, and I'll cover some next steps and resources before we again get into our discussion section. Okay, so starting with an overview. Sequencing, just to be clear as to what we're talking about, because it does differ from the nucleic acid amplification test, is a laboratory procedure that determines the order of the nucleotides in a genome. So this is the RNA or DNA. So essentially, what we're talking about is looking at what is the code, the genetic code of the mycobacterium that's inside of the person. Next generation sequencing is a high throughput sequencing method used to determine the nucleotide sequence of a genome in a single biochemical reaction. This differs a little bit from Sanger sequencing that used to be used as a first generation. So this is an evolution of the technology. It is, however, a method. So keep that in mind. Sequencing is traditionally done, next generation sequencing is traditionally done through 4 steps. So first you have the extraction of your DNA. So this is where the mycobacteria from a patient sputum sample, in this case for targeted, is pulled out. The cells are lysed so that the DNA is released from inside the mycobacteria, and then it's purified for phase 2, which is where it's prepared for sequencing through what's called library preparation. The sequencing is done by instrumentation at this point in order to determine what is the sequence. And then it is the data that comes off of the instrument is run through a software analysis that can compare it back, for example, to a reference sequence, figure out what the order of the bases that were read should be, and whether or not there are differences between a reference. So this is what allows us to identify mutations. We know what the sequence should be when there's no drug resistance and no mutations, and we get a patient sample, we pull out the mycobacteria, we break open the mycobacteria, we pull out the DNA, we prepare it for sequencing, we read the order of the nucleotides, and we compare those to what we think it should be. And when there are differences, we can look to see what those changes are. And then we'll talk through interpretation of how we determine a little bit of resistance. So whole genome sequencing is one way of using next generation sequencing as a technology. So we have whole genome sequencing and we have targeted next generation sequencing. And these are 2 slightly different approaches to the use of next generation sequencing. Whole genome sequencing, as shown here, investigates the entire genome of the mycobacterium that's pulled out. So you're trying to get the full order of the nucleotides across the genome. This is the most comprehensive approach to next generation sequencing. It gives you the most information for things like comparison of whether strains are related, for example, because you can look across the whole genome in order to compare different strains. However, you typically get less depth. So you get, because you're focusing on length, you're not focusing on targeting a certain section in order to get a depth. And this one does require a TB culture in order to get the full genome at the moment. When we're talking about targeted next generation sequencing, this is where we're using sequencing to determine the nucleotide sequence at specific regions of the genome. And in general, for drug resistance, we're targeting the genes or the genomic regions that we know harbor mutations or changes that are associated with drug resistance, that change something in the bug that make it resistant to the antibiotics we use to treat TB. This is adaptable to new genes because you can add new primers and you can change where you're targeting over time, which is helpful for the technology. You get greater depth, so you'll see 2 here versus 1 brown circle there. So you can understand a little bit better what kind of variability you might have within your population of mycobacteria from a sample. It results in a faster turnaround time because you can use a clinical primary sample, in this case, a processed sputum specimen. And it has lower data requirements, which is a practical and operational consideration, but an important one for programs because all sequencing tends to generate a good amount of data that needs to be stored and then analyzed with computing power. Okay, so now we're all on the same page. We know what sequencing is. Moving forward for the WHO recommendations. And what I'd like to do is just walk you through time. So we're going to start in 2018 and work our way up to where we are now. In 2018, WHO worked with FIND and issued the initial use of next generation sequencing guide, a technical guide. This was because it was relatively new to the field at the time, and the information was useful both for manufacturers and for public health programs for preparedness and for considerations for surveillance. We also had drug susceptibility testing, critical concentrations updated that could be used to interrogate what kinds of early sequencing data were coming along and how to interpret the results. In 2021, the WHO guidance for surveillance of drug-resistant of TB recommended sequencing for the first time for drug-resistant tuberculosis for surveillance purposes. For those who are interested in this, who haven't referenced it, there are some example algorithms for use in things like drug-resistant surveys, considerations for sampling in here, all related to surveillance. That same year, WHO issued a target product profile for next generation tests that considered drug susceptibility testing, including potential use of sequencing, and the first catalog of mutations in Mycobacterium tuberculosis complex and their association with resistance was issued. This was our first global standardized resource to say, okay, when you look at your sequence, if you find these changes, we have an approach and a standardized way to look at the biggest database of global data that we've had to date in order to determine which mutations are associated with resistance, which might be associated with resistance, and which are not associated with resistance. In 2022, we saw the updated drug-resistant TB treatment guidelines, which changed which drugs we need to do drug susceptibility testing for. Drug susceptibility testing always follows the drugs that we use to treat the disease, right? And so we saw some shifts in which drugs would be included. The Catalog of Mutations second edition was issued the next year, and this incorporated advances in our understanding of the molecular basis for resistance, particularly when it came to some of the new and repurposed drugs that were being used in the new regimens. We also, at this point, had this first rapid communication around the use of targeted next generation sequencing from a clinical sample for clinical management of drug-resistant TB, and an implementation manual on the use of next generation sequencing. Then most recently, we had our guidelines that incorporated this rapid communication information, the way we're talking through. This incorporated an algorithm that considered the availability of targeted next generation sequencing results for interpretation of drug-resistant TB testing in order to guide treatment. And there was an update to the target product profile for TB and drug resistance detection that considered peripheral drug resistance testing needs. So that brings us to where we are now. So these are the targeted next generation sequencing recommendations. So in the latest version of the guidelines and the operational handbook, you'll see this new down here. There was a new section introduced on targeted next generation sequencing. This formed a new class of diagnostics, and there is a class of targeted next generation sequencing for drug-resistant TB detection. And this is the definition. So these are often referred to as end-to-end targeted next generation sequencing solutions. What that means is we're not talking about a test anymore. We're not talking about an ultra that goes into a machine. We're talking about an entire procedure at this point that uses this technology. So this is massive parallel sequencing that starts with the use of a clinically processed sputum sample and works its way through a defined procedure using a certain reagent kit from a company and a specified sequencer or sequencing technology that gives an automated result for resistance at the end. There are still manual steps in between, and it does still require laboratory infrastructure that it can accommodate a separation of molecular clean and dirty spaces in order to get to a result. From this first 2023 recommendation, we had 3 products recommended for which eligible data met the class-based performance criteria. These were the D-plex MycTB assay, and the drugs for which the recommendation covered are listed here, and I'll talk more about that in a second. The Ampor TB solution and the TB-Seq solution from China. It's thinking. There we go. So just taking a quick look at the performance of the 2023 recommendations, And then we'll talk a little bit about the new products and how they relate. So TNGS was found to be accurate for drug-resistant TB detection by the guideline development group that reviewed the systematic review evidence for assessment. We looked at two populations. We looked at the use of targeted next generation sequencing among those with bacteriologically confirmed TB for resistance to the first-line drugs, and then also the use of the technology for the detection of resistance among rifampicin-resistant patients for detection of resistance to the second-line drugs. And this is really based around how the results would be used to guide therapy, despite the fact that the tests and the solutions will provide the resistance profiles for all drugs from a single sample. For the people with bacteriologically confirmed pulmonary TB, they were accurate for all drugs assessed. So there was a pooled sensitivity of greater than 95% for rifampicin, isoniazid, moxifloxacin, and ethambutol, 94% for levofloxacin, and 88% for pyrazinamide. And the specificity was greater than or equal to 96% for all drugs. Among people with bacteriologically confirmed rifampicin-resistant, so TB, so now looking at the second-line drugs, it was found to be accurate for isoniazid, levo, moxi, pyrazinamide, and ethambutol. These are yellow in the table because they have pooled sensitivities of greater than or equal to 95%. And it was acceptable for bedaquiline, linezolid, clofazimine, the second-line injectables, and pyrazinamide. With lower levels, these are shown in orange. For the new and repurposed drugs, it's not because the technology performs poorly for these drugs. It's because we simply don't know enough yet about the targets that we can include in the assays to determine resistance. The guideline development group also determined that the technology was cost-effective, again, depending on setting on context. And we talked earlier about the difference between cost-effectiveness and affordability considerations for programs, but it was determined through modeling to be cost-effective compared to culture and drug susceptibility testing for both first and second-line drugs, because those are actually quite costly, as many of the programs will tell you here, based on the staff and the infrastructure required, along with the reagents and the equipment. And it was determined to be acceptable and implementable despite inherent complexity based on early adopters across a burden of countries that had already demonstrated access for surveillance purposes and built capacity, even for other pathogens before TB. These are the 2023 recommendations, and apologies, these are a bit small on the slide, but essentially based on this performance in bacteriologically confirmed TB, they were recommended for use. This was a conditional recommendation, so they may be used for resistance to the first-line drugs. That the remarks here are very important because of the cost effectiveness and feasibility and complexity concerns. The guideline development group felt very strongly that there should be this stratification around priority be assigned to those at higher risk of resistance to first-line treatment here, as opposed to universal access, which would be more research or more resource intensive. Among the bacteriologically confirmed rifampicin-resistant pulmonary TB cases, targeted next generational sequencing was recommended for resistance to the second isoniazid and the second line drugs. Again, a conditional recommendation here for isoniazid, fluoroquinolines, and pyrazinamide, moderate for ethambutol, low for bedaquiline, linezolid, and clofazimine, again, based on performance and the level of evidence available. And priority should be given to those at higher risk of resistance for the medications used to treat rifampicin-resistant TB. So again, among those in this population. Okay, so I said this at the beginning, and I'm going to repeat it again because I think it's really important, even though we're talking about sequencing. The implementation considerations specified in the guidelines and according to the guideline development group highlight that the targeted solutions do not replace the existing rapid tests that are more accessible and easier to perform for the drugs that we have available. However, if targeted NGS can be performed rapidly, it can be considered as an alternative initial option because it can be done initially from a sputum specimen and therefore speed time to resistance results across a wide variety of drugs faster than you can get results from culture and drug susceptibility testing. Priority should be given to samples with a high bacillary load, and this is because you start to see a higher rate of indeterminate results across one or more drugs as you get lower and lower mycobacteria in the sample. So bang for your buck is higher with a higher bacillary load. And since sensitivity for bedaquiline, linezolid, and clofazimine was suboptimal, consideration of the pretest probability is important when guiding results. We talked a little bit about rifampicin resistance results and what to do in a low pretest probability setting when you get that positive result. This is something that needs to be considered, particularly with these drugs. If you get a positive result that's associated with a resistance-associated mutation, that is a signal for bedaquiline resistance. But if you're not expecting it, you've never seen bedaquiline resistant, that patient is not anticipated to be there, then that is a clinical evaluation, and phenotypic results may help. Okay, so we talked about the recommendations. We talked about the first three solutions. Over time, since the 2023 recommendation, we see more development of new technologies. So similar to the molecular tests, there are more targeted next generation sequencing solutions, either in development or undergoing updates. And so two of these that came forward was the ONT Ampor TB reagent kit. That should sound familiar because it was recommended as one of the first three in the 2023 recommendation. But the company went back and did a software update. They incorporated the latest version of the WHO mutations catalog for how they called resistance, and that changed the performance of the test across drugs. Then there was also a ABL Diagnostics South Africa Deep Check Assay 13-plex KB reagent kit. This was actually in the initial field evaluations that were done for evidence generation by FIND alongside the other solutions. Two of the other solutions that were initially evaluated. However, the data analysis had not been completed in time for the initial guideline development group. So at this point, the company felt the solution was ready and the analysis was complete for assessment. So we issued in 2024 a targeted manufacturer call. We reached out to manufacturers that we knew were developing these solutions and also did a public call for data. And they were assessed for performance and for the qualitative evidence to a more minimal assent because the class had been established. So this was a technical advisory group assessment for the first line resistance, again, among people with bacteriologically confirmed TB, and again, second line resistance among the rifampicin resistant TB. So same populations and using a very similar assessment protocol. This is a very busy slide. I'm having it here for you for reference in case you're interested in advance of the guidelines. But what you will see is among the bacteriologically confirmed TB, we have the drugs listed here and rifampicin resistant drugs listed here. The columns show the Ampor TB solution against the pooled within class performance from the 2023 guidelines. The numbers are not as important as the colors. So everything that is green here had improved performance compared to the class. And that's a lot of updates. That's a lot of improved sensitivities. We did, however, see some lower orange performance, particularly for ethambutol with this particular solution. And so this is something that the manufacturer is working on currently. The reason that I'm showing you Ampor TB is because this is the one that was found to be comparable and moved forward. The second solution was found to not have sufficient evidence. They had used different extraction methods for the laboratorians in the room that varied the performance potentially across sites, and they had higher indeterminate rates with the deep check solution. And so I'm showing you the one here that will now be included and for which the TNGS recommendations were extended in the next guideline set. So the performance of the Ampor TB solution, again, the updated version, just new software, is comparable to that of other WHO TNGS solutions for the detection of resistance, again, first-line resistance, second-line resistance for those populations. The performance of the Deep Check assay could not be adequately compared because of the evidence available. And the WHO recommendations are valid for the Ampor ONT solution. There are 2 points here. So we have the same set of 3 solutions, but for this Ampor TB, essentially the updated assessment added a recommendation for the use of the solution for 3 additional drugs for which it did not meet the initial criteria based on its analysis software. Those are pyrazinamide, bedaquiline, and clofazimine. Those were not included in the initial recommendation. So that's the first point to highlight of the difference between the 2023 guidelines and this one. The second point that I want to highlight is that this means that with no chemistry change, no procedural change, only with an update to the software, performance changes. And that's something that will be continuing to evolve for these solutions. As we understand more and more the molecular basis and the targets for mutations associated with resistance, we can update the mutations catalog to incorporate that information, and then companies will update their information as well. So because of that, we expect to need to re-review these products as the performance advances, and we will also in the future be updating the within-class performance over time so that it reflects improvements in performance, and new products that come in with, say, baseline performance won't be assessed according to the initial baseline. They will be assessed according to what the pooled performance is of all the products in class. So just highlighting, as I mentioned earlier, that the operational handbook does have this algorithm that incorporates targeted next generation sequencing based DST, where it's available and how to use it, for which drugs phenotypic DST is still recommended, and then how to interpret those findings. This remains in the new operational handbook. In addition to that, we have information sheets that were developed in collaboration with the Stop TB Partnership Global Laboratory Initiative for each of the technologies. This provides a brief overview of what the technology is, what the procedure is, the different implementation considerations for their use, requirements for equipment or resources. So please reference these. They're included in an annex to our operational handbook. So in summary, we have 2 new NGS solutions, assessed, 1 recommended by WHO. Forthcoming operational handbook, again, will include the new solution policy statements. It will also include as an annex the full systematic review reports and the outcomes from the technical advisory group meeting. Advances in our understanding of the molecular mechanisms of resistance will impact the performance of these and the interpretation of these over time. And so we will be, we're preparing to release an updated version of the mutations catalog this year. So that would be the 3rd edition. And we'll start preparing for the next 4th edition, ideally in a fully online status in the future. If you have sequencing information from your country, particularly whole genome sequencing results that are matched with phenotypic testing results, we welcome those. They help inform the mutations catalog. We have a TB sequencing portal, an online website that we can share where that data can be uploaded and included in future analyses. And that's the end of the presentation. Thank you.
Thank you very much, Patricia. We now have a short questions and answers sessions with Patricia, and then we will move into country experiences of 2 countries. And then we will have a broader discussion among ourselves. So first, clarifying or other questions to Patricia on the exciting topic of new generation sequencing. And while you're preparing your questions, maybe I can open with one question.
Sure.
You on your slide, you mentioned that next generation sequencing is about massive testing or something like a high volume testing. Is that always the case?
So it's massive parallel sequencing, which is a bit of a technical phrase that basically means that sequencing can be done across a genome in a single sample for all the various targets. So it's not necessarily high volume in that you can do a lot of samples at once, but you can do a lot of sequencing of one sample at the same time without having many, many reactions needed.
Thank you very much. Yep.
Thanks, Patricia. Maybe just one thing to underline, which I think is really powerful when we speak about, especially with countries here in the room, is how much the country input actually improves this technology. And there was a one to the last bullet that you had in your summary, which really emphasizes that the data that comes from countries on sequencing, on mutations, is actually feeding into the catalog, then it's used by the manufacturers to improve the product, which WHO reviews, and we have a better product. So just to emphasize, first to thank the countries for sharing. It has been an amazing journey. And I think now we have 75,000 mutations actually in the mutation catalog, which is enormous. And actually without the countries, we wouldn't be there. But second, to say the more we contribute, the better these tests are going to be, because any other tests would need years to be improved. These tests are actually really requiring a much shorter time frame to be improved, but for that we need data from countries. So maybe just that emphasis of that kind of cycle of collaboration is really good to have. Thanks.
Absolutely. And we'll make sure we circulate to the participants that that website. Apologies, the final slide seems to that has the QR code is not there today, but we will we'll circulate the website where people can go and review. It's called the TB sequencing portal. You can also use it to look at a world map and look at mutations kind of in resistance frequencies across the world. You can search for mutations in there and see what the database says. So thanks, Milka, a very important addition. And thank you to the countries.
Thank you. While we continue to think of questions, and we'll be opening to the discussion session after this, I would like to go to Dr. Shifa Kumar, the head of bacteriology at ICMR India Chennai, to give some of the reflections from the region. Dr. Kumar.
Thank you. I'm Dr. Shiva from the National Institute for Research in Tuberculosis, which supports the program for their and National TB Elimination Program for their policies. So what we have done is we have looked at
Dr. Kumar, are you still talking? Unfortunately, we seem to have lost connection.
Yeah.
Please go ahead.
Yeah, thank you. So, so what National TB Elimination Program of India has thought about on introducing targeted next generation sequencing, especially for the people who are going to undergo BPAL regimen, because recently country has rolled out BPAL regimen, BPAL-M regimen in the country. So to support this, what presently we are doing is we are trying to take out all the Center for Excellence where these BPAL regimens are rolled out, and collecting the samples which are baseline samples, and then performing targeted NGS mainly by NanoPo, because we want to roll out this into a number of centers. That is at least 15 centers. Initially, we have started with 5 centers. And since installing these instruments is quite easy, we have ventured into nanopore, and the cost per test also is quite low. And looking at the numbers which we have to sequence, which is around 70,000 per year, more number of sites also is needed. A single site will be not possible to perform 70,000 isolates whole genome sequencing or targeted next generation sequencing. So the targets which we have included, which is approved by WHO presently, but then would like to add more targets and generate data on pretonamide, delaminate, and for that matter bedaquiline as well, so that we can contribute to the WHO catalog to increase the sensitivity and specificity for calling this resistance mutations, and simultaneously we will be doing phenotypic test as well for all these isolates. The challenges which we face in introducing is training. Yes, initially 5 are trained, but then we'll be training more centers for introducing this, and we are expecting the cost to be somewhere near around $50 to $60, not more than that, to cut on the cost as well. So apart from this, we are also planning to introduce some other technologies as well, which are coming new. But then initially we have thought of nanopore for ease of rollout and ease of cost in that matter. So going on to the strategy on which this drugs will be called for mutation, we have mutational catalog from WHO as well as mutational catalog from India, which was developed along with CDC on 2000 samples. Later, some of the cryptic data from India was added to it, and now we have a catalog which has 10,000 isolates and around 11,000 to 12,000 mutations. And this we have done it as an exercise because the most common strains in India are 1 and 3, whereas in other countries it's 2 and 4. So just to balance out that, we have done another catalog, and we have combined this catalog along with WHO catalog for calling the mutation to be very with a high confidence we can say whether it is resistance or this is again an ongoing process. We will be doing generating data for pretendamide, delaminid, as well as linezolid and bedaquiline as part of BPAL regimen, because we are going to do phenotypic test as well as TNGS for all these isolates. So at the end of year, probably we'll have a huge data to share with WHO as well as to improve our outcomes in terms of the reporting of targeted NGS. That's all from my side. Thank you.
Thank you very much, Dr. Siva. Maybe there are questions for Dr. Siva, please.
Thank you. Thank you, Dr. Siva. I appreciate really very much Bangladesh sharing that in different fora. Just to clarify a couple of things, maybe a programmatic side of this. Just if you can unpack a little bit more on what were the considerations when you were selecting the technology? Have you worked with anything which was already on the ground in terms of sequencing? Because we know that COVID brought a lot of technologies, and whether you could work with that. The second one is in context of the NTP, how did this affect management of cases and treatment decisions, etc.? If you can unpack a little bit that dynamics in the country of rolling it out for the purpose of the program. Thanks.
Thank you. So the first questions in terms of why did we select the technology, or I mean whether we have looked at other technologies as well, like MGI or any other technologies. Yes, of course, we have looked at other technologies as well. The present issue was on the cost, and we also looked at the performance based on the previous report from WHO. Performance-wise, both Illumina and Nanopore were almost equal, and we also looked at the data which was presented in the recent union conference. And another thing which we have done is we have looked at the FIND study, seek and treat, in which around 300 to 400 isolates were used for nanopore, Ampore nanopore sequencing. So based on these evidences, we have selected. But then we also wanted certain additional drugs, which is pretendamide, so which we will be adding from our side of as a separate tube, so and mix it for sequencing, or we'll be asking the company to do it. So that was the first question. Second question was how implementation of these. Presently, it is not really implemented. These are under trial in Center of Excellences, mainly because this was used to support the BPAL regimen, will be used to support that BPAL regimen, and presently the BPAL regimen has been rolled out only in Center of Excellence to monitor ADAs and other things. So these were two considerations which we thought before taking into nanopore as a platform. But then we are not limiting ourselves with nanopore. As and when we move forward, we will also be utilizing our own Illumina sequences, which we have put in program, the National TB Elimination Program. We had looked at utilizing the capacity of sequences which were installed as part of the INSACOG or the COVID seek. But then these we will be using those if they are close to these labs where all these liquid culture will be done. But then if it is little far, we will be not using them. That's the present way of putting it across. But then in future we definitely look forward to use them as well for capacity building, training, as well as for reporting the drug resistance. Thank you.
Thank you very much, Dr. Shiva. Can I have one question to you also? Which assay are you using? Are you using the Emperor TB?
Presently, we have the one which is homegrown. The sequencing technology is nanopore, but then we are using the homegrown primer set presently. Yeah.
Thank you very much. And we also have online Kristen Kramer from KNCV. She's also working with sequencing. Let's have her contribution to the discussion as well. Kristen? Mansa, can you check if Kristen is online?
Hello?
Yeah, please come in.
Okay, great. Well, hello everyone. Very nice to see you all. Thanks very much, Patricia, for the update, and wonderful to hear all the countries' contributions to this session and the previous one. I have indeed a question for Dr. Shiva. Are you using the MinION platforms or are you using the GridION platforms?
Presently, we are using MinION platform. And we are planning to do close to around 48 samples per flow cell. We have just little standardized on 48 samples, and we are not going to put more, and this will work on the cost as well as the time. So we're planning to give the results within a week. So in a week, we'll be in a center, we'll be able to run around 48 sample, preparing the library and everything.
That's wonderful to hear, and also interesting to hear that you're using a homemade test. And I understood you also have extended targets maybe included for some of the newer drugs. Is that correct?
Yes, you are right. So since this is homegrown, we have included targets which are already reported, like for pretenamide, if you see, we have included FB, I, A, B, C, FGD1, and also DDN for the bedaquiline, we have RV0678, which is the most common in our places, or at least in 1 and 3, because we hardly see any ATP. We hardly saw any ATP. In fact, we don't know the future. Yes, so these are included. Linezolid also, RPLC is included. So Yes, all, and these are not targeted based. We have we amplify the whole gene rather than targeting only the mutation where the hotspots basically.
Okay, thank you very much. And I'm sure also otherwise Patricia would say it, but of course, also having the contribution from India to the overall catalog would be very valuable. As you pointed out, you have particular lineages of M. tuberculosis strains that are not so prevalent in some of the other regions where most of the sequencing data is from. So congratulations on your work. Thank you.
Thank you. So to add on, so we have present in the next catalog, our collection of around 500 has been added already to the new catalog which is going to come. But then we are trying to add some more once those are published. Thank you.
That's wonderful.
Does anybody in the room have any questions for Dr. Shiva or the KMCB colleagues, sorry, Christine? Because it sounds like they have a wealth of practical experience, so please make the most of the experts we have.
Thank you, Patricia, for this nice presentation. Just to set the scene for Papua New Guinea, we did not introduce this new technology yet. We are in the initial discussion on how we could introduce in our country. So I have a few questions to ask. Is that do WHO has an assessment list on how we could, for the initial step of setting up something in the country? For us in Papua New Guinea, we'll be looking at the targeted next generation sequencing because we have a lot of challenge with our sample quality, and most of the samples, when we send for phenotypic DST, they don't grow. So we have a lot of no growths. So that's something that in the country we'll be looking at working on the raw specimens. And that's the approach that we want to take. And if WHO can give us a guide on that, on how we could do some initial steps and to start that in country. For us in country, it won't be a full, sort of the full four steps. We'll be looking at doing parts of the steps and maybe do the reading, maybe sequencing some offshore. That's an approach that we are looking at. And if there is some country in this room that has that sort of approach, if you can share some advantages and disadvantages of those implementations that you have done in your country, so it can assist us with that. Thank you. Yeah.
Thank you. Bangladesh had a study in the targeted next generation sequencing, which was done in the 2022 organized by the ICDDRB, funded by the USAID funded. When that result reveals that, we can see the higher sensitivity for the rifampicin was 99.3%, isoniazid was 96.3%, and fluoroquinolone was 94.4%, and aminoglycosides 100%. But comparatively, compared with the phenotypic drug sensitivity test, but sensitivity of the targeted next generation sensitivity sequencing for the INS, rifampicin, fluoroquinolone, aminoglycosides were 93, 96.6%, 90.9%, and 100% respectively, and specified range from the 91.3 to 100% when compared with the composite reference standard. That is the proof, but we know that the targeted next generation sequencing is the promising WHO recommendation diagnostic technology for the tuberculosis and rapidly identifies the drug resistant profiles, adding more effective treatment decision and offering a comprehensive alternative to traditional methods. In Bangladesh, NTP yet to not able to introduce the technology in the program. Only we have done one study in our ICDRB in 2022. But still NTP yet not able to introduce the technology for the program. NTP don't have any budget to introduce this technology in the program. There is a plan to organize a stakeholders meeting introduced by the USAID and WHO to initiate the functions in Bangladesh in the future. Nowadays, we are doing XDR cartridges in the molecular diagnostic tools, and we are performing the drug sensitivity tests in there. And from that sides, we are manage the MDR patients in Bangladesh. Thank you. Thank you from the Bangladesh side.
Thank you. And Patricia, maybe do you want to give any feedback to the PNG question? Because I have a slight follow-up question to that, but we'll give an opportunity first.
Push the button. There we go. Once again, echoing throughout the room. Thank you for the questions. I think a couple of points are interrelated that Dr. Shiva raised and that have been asked, and that's around kind of the models and the use cases for implementation. So Dr. Shiva and his team have done a nice job of implementing sequencing for research and for surveillance as kind of interim approach toward clinical use. Several other countries that have been funded through either the USAID projects, such as Bangladesh, or through UNITAID and Find, Seek, and Treat initiatives, have looked at implementation of whole genome or targeted sequencing. And other countries have been working on their own to consider their COVID capacity and kind of multi-disease implementation. I'm saying this because there, I think, have been a lot of different experiences and use cases to date, and we're interested in now bringing that information together. And so there will be more resources coming forward around use cases. However, in the meantime, we do have the implementation manual for next generation sequencing that was published by WHO, and it does have some practical tools included in it. So sometimes these manuals describe things, right? There's kind of a guide or an overview. This one has tools, and one of the tools is for assessment. So that could specifically meet your need. In addition, there is a new manual that's under development specifically for targeted next generation sequencing for clinical use. And that one will include, for example, the verification and validation tools that you would need for quality management systems to incorporate a new test into your testing menu. So we're working with the Global Laboratory Initiative, Find, Seek, and Treat, and others in order to try and get that finalized and published. The other thing I would say is that I think as we move forward, please do share these experiences. Please publish this work and come to us and share your experiences for implementation and for what's working and what isn't working. There are countries that have had some great successes working with their national public health institutes and their national public health reference laboratories, using the capacity that's available so that all the cost doesn't fall on the TB program for implementation. There are others that have found that depending on their volumes, it may be really useful to have a small sequencer in the TB laboratory to do initial sputum specimen testing in order to speed the resistance results. So monitoring the implementation of this, monitoring different phases and asking these questions and cross-sharing is something that we're very open to, and we'll continue to find ways to try and bring countries together to share their experiences.
Thank you. Okay. I don't want to monopolize any time, but I did also want to share with the group, these diagnostic tests are fantastic, but there is also a need to link them with some of your clinical management decisions. Other experiences from outside this region have shown that when you start looking for resistance to many of these new drugs, you're going to find it, right? And so as we roll out all these newly recommended WHO all oral shorter regimens, they all contain bedaquiline, they all contain linezolid, and they all contain a third generation quinolone. So there will be management decisions that need to be made about populations of people whose strains of TB are found to have resistance to these agents.
And in particular, it's important to have some clinical decision-making support when there are mutations detected that are of unknown clinical significance. So there's some really nice examples of how this was done in the country of Eswatini, who's rolled this out nationally over the last 2.5 years, and would be happy to share that with any of you in the room who are looking at this as well, because the lab support is great, but then knowing what to do with the results and how that impacts the management of people is also very important. So thank you.
I can share some from Thailand. Thailand start the next targeted. Just this year, we are targeted at the pre-SEAR first, and to make sure that we can have the pre-diagnosis from the targeted next generation while we are doing the phenotypic culture, and then we hope that our clinician can know first, as you said, so that maybe they can choose the drugs before the phenotypic come out 2 months later. But for the MDR and RR TB in Thailand, we have about 1,000 a year. We do the research with the whole genome for about a year, and then maybe we can contribute the research result later.
Thank you very much for the Thailand experience, and also for your addition, Jennifer, on the clinical relevance and the need to also define steps forward once you have the resistance. Kristen, you also had some additional information to share on the implementation of the implementation steps of next generation sequencing.
Yes, thank you, Agnes. I just wanted to also confirm what the previous speaker said, that indeed, of course, we really also want to use this for patient management. In that sense, I would like to share also that we are doing a demonstration study in Kyrgyzstan, and that Kyrgyzstan, since the beginning of this year, has really taken this step that also results from targeted sequencing will be reported to the clinicians, so they can actually also use all this information for the patient management, and also to give the audience an idea about how well this technology works on sputum samples. So in our validation study in Kyrgyzstan, we had a 96% success rate of sequencing results on sputum samples that are also positive in Gene Expert. So I think that is really also quite a good achievement. And of course, what is very much needed still is to see what is really the added value of these targeted sequencing technologies for patient outcome. And for that, we have also initiated a study in Kyrgyzstan, and for which the patient inclusion of over more than 1,000 patients has just been finalized. So we're really very much looking into analyzing that data, of course. But we can already say that, indeed, we see a very good concordance between targeted sequencing by using nanopore sequencing and the standard of care DST methodologies. And also we have compared the two sequencing technologies that are recommended by WHO. So the nanopore sequencing and the GenoScreen solution that's based on Illumina sequencing. And they gave really good concordance, and especially, of course, for the high confidence graded drug resistance associated mutations. And maybe what's also very nice to hear for the audience, that as a kind of bonus, you can also identify strains that are not of M. tuberculosis complex, but non-tuberculosis mycobacteria. So that's also can also, of course, be interesting and important for patient management and other actions to be taken. Over. Thank you. Oh, and also I wanted to say that we are also collaborating with a similar study in Tanzania and Vietnam. And I thought maybe Vietnam would like to say something about what they are doing and what they are planning to do in the coming period. Over. Thank you.
Thank you, Kristen, because I was about to do my tour of the tables asking for what other countries' plans were for implementing or planning to implement targeted next-gen sequencing. So I don't know if Vietnam would like to start with kind of what you're doing with KNCV and maybe how you're thinking of scaling that up.
So on behalf of Vietnam NTP, I would like to share some experiences from Vietnam. So a long time ago, we already conducted with the whole genome sequencing for study purpose for surveillance. And recently we have a chance opportunity for the TNGS with the AMPOL, with the collaboration with the KNCV. And we also have a chance to conduct a small validation with the DeepLab, the Illumina sequencing platform. So in overall, the TNGS is show the high accuracy of the sensitivity and specificity, and importantly, the TNGS can able to detect the borderline resistant as well as some hetero-resistant and mixed infection that the phenotypic DSC, the conventional method, cannot able to detect. That can misdiagnosis for the drug resistant TB patient. So I think that's a good strategy to implement the TNGS for TB patient care. But in Vietnam, with the TNGS kit, we with the Illumina platform, the kit got the IVD certificate. So, but with the AMPOL right now is still under pending with the RO not IVD certificate available. So right in the meantime, we decided to roll out with the Illumina platform kit and the routine test. So with the AMPOL, we know that the technology can have a similar concordance, but the barrier is the IVD certificate. That's a barrier we cannot use for the clinical practice. Yes.
Chúng ta nói tiếng Việt một chút cho nó buồn ngủ nhé. Ở Việt Nam thì chúng tôi cũng không chỉ dừng lại với TNGS ở nghiên cứu hay là một dự án, mà chúng tôi cũng đã đưa được TNGS vào trong cái xét nghiệm thường quy để chẩn đoán tính kháng thuốc cho bệnh nhân ở trong nội viện. Và trong thời gian tới thì chúng tôi cũng mở rộng những cái xét nghiệm của TNGS với lại kênh chi phí là từ bảo hiểm y tế.
So Dr. head of Vietnam NTL, she would like to add some more information about the TNGS implementation in Vietnam. So now with the TNGS, we already put the TNGS in the testing service list in our hospital, the National Lung Hospital. And so in the near future, we are planning to put the TNGS in the testing list to be paid by the health insurance. Yes.
That's all. Thank you. Any other countries want to share? Because I think maybe to the Bangladesh experience, just sort of, and from Vietnam maybe as well, of kind of how is the TNGS and the questions that have been said. There was a lot of procurement during COVID, and that was not within the TB program. That was sort of more within the national diagnostic strategy and infrastructure. And our countries, and I've sort of, Bangladesh, maybe you want to fill in the gaps here, but is this something that is being thought about as a TB specific sort of approach, where the TB program is procuring the platforms and managing the platforms, or is it trying to sort of integrate with maybe a more broader national diagnostic strategy around next-gen sequencing, both whole and targeted, and that sort of point of, is this something that the TB program has to support financially, all of it, or can it fit in to a broader strategy and therefore have some of the other costs covered? And I wonder if any countries have any reflections or how they've approached that. And I know we should have some lab focal points in the room as well of kind of how that, are those discussions happening with the broader lab directorate around this being a sort of multi-disease, multi-pathogen platform. So, but I see Patricia was standing up, but just to, if anyone wants to give any reflections on that, that would be very interesting to get a sense of, is this being viewed as very much driven by the TB program for the TB program, or is it part of a broader national strategy? I'm going to warn this table here that I'm going to come to you in a minute. So think about what question you're going to ask or what you're going to present that avoids you asking a question. So, any thoughts? Okay, your time has come. Anyone in this table want to either give a reflection on what you're planning targeted next-gen sequencing, or or you're seeing this with broad. They're turning the mic off on me. How you're viewing it as a national diagnostic strategy?
Yeah. For Nepal, I think we have planned to have a next generation sequencing, maybe the duplex, I think, in a central lab, but there is a lack of funding. So it's not possible. Maybe in the next NSP, we are going to make within a year or two, we'll plan for the next generation sequencing in at least the central lab at the National Tuberculosis Program Central Lab. So only that, maybe, but not sure.
And have you had any, have you had any conversations with the sort of larger lab directorate around if there's existing platforms that you could utilize to save kind of it all being on the TB program?
National Public Health Laboratory. National Public Health Laboratory have this genome sequencing actually, but they are using for some other program, not for the TB program. Sometimes if needed only they can do for the TB program. And that's why targeted genome sequencing we want to establish in our National Defense Laboratory of the tuberculosis.
Great, thank you very much. Any other questions or comments linked to this or anything else on that we've talked about this morning? Coming.
So two issues that I don't think have been raised in this session that are probably worth addressing with countries are big ones. One is cost, and the second is the efficiency of the process to get a valid TNGS result on patients who have been diagnosed with rifampicin-resistant TB. So these are patients who have enough bacteria to generate a more than trace positive expert call. So they're not so paucibacillary. What are the efficiencies of the process that make implementation possible? Like, in other words, how many of the 100% of proportion of patients with diagnosed with RIF-resistant TB today, how efficient should the process have to be to make TNGS a viable programmatic solution? And are the current assays achieving that process, either the commercial assays or the homebrew assays, such as Dr. Siba presented? And the second is, what are the cost structures for TNGS applications which are going to make it a viable programmatic solution moving forward? So what is the, I guess the cost structure that's currently there, and what is the structure which will make it, genuinely scalable to the extent, for example, like Siva mentioned, they're looking to do but don't see the pathway just yet. So I'd love to just, if those programmatic considerations could be taken on, then that would be great. I'm thrilled to see high sensitivity and specificity for new drugs, but it has to work for most patients in order to be a viable asset to the programs. Thanks.
So maybe we can have Dr. Shiva and Kristin comment on these two issues. Is Dr. Shiva still online?
I can say something. I'm still here.
Yes, please. Go ahead, Kristin.
Yes, yeah, very good points. And I don't also have the answer yet, but I do hope that that we will be able to say something about more about that in a year or so, because we are also currently doing studies on the budget impact and costs of nanopore sequencing in Kyrgyzstan, and we hope to extend that also later to the other countries that we are working with. And I think there it should also be taken into account, of course, what are in the end the benefits of implementing such a method, and that is, of course, that we can give the right treatment to the patients. Maybe over to Dr. Shiva if he wants to add something to this.
I don't think we've Dr. Shiva online, but I do see that Maria Regina Christian has her hand up. So please go ahead.
Thank you for the opportunity. I'm Maria Regina from Indonesia. So maybe I can update you a little bit experience from Indonesia on implementing the whole genome sequencing. So the first time Indonesia conduct the whole genome sequencing is part of the drug-resistant TB survey in 2019, whereas we conduct the whole genome sequencing for subset of its samples. It's around 1,300 samples from the DRS was analyzed by sequencing method. At the time, we have the capacity building from WHO laboratory hub in Milan to have like 2 weeks workshop for the capacity building for the whole genome sequencing. And later, during COVID-19 pandemic, we received the C19RM funding for procurement of more genomic sequencing machines. So in total, currently Indonesia has around 62 NGS machines all over Indonesia for I think it's in 43 laboratories. So last year, we conducted an assessments and developed the roadmap of genomic sequencing for TB. And here we have 3 phases. The phase 1 is for the 2024 is to do the preparations and build the capacity building. Phase 2 for the 2025 to 2026, we will use the NGS-TB for the drug-resistant surveillance. It's underway, the planning and the preparations. And the phase 3 for 2007 to 2029, we plan to use the NGS for the clinical management. So having a strong genomic sequencing also part of the Ministry of Health Indonesia priority. So in 2022, the Ministry of Health established the BGSI, the Genomic Sequencing Indonesia, which is have some priority diseases to be screened, and tuberculosis is one part of the priority disease. So we also receive the funding from C19RM to strengthen the BGSI works on doing sequencing on TB. So the idea is to have 2-pronged approach. One is for comparing the genomic sequencing with the whole genomic sequencing with the NGS, and also having the samples from drug resistant sample and the drug susceptible samples. So as far as I know, by the end of 2024, the DGSI have started conducting whole genome sequencing for BEPAL, since Indonesia is also has already implementing the BEPAL. So by the end of 2024, we already have like 51 samples underwent the examinations, and we will follow up about the results. So I think for Indonesia, lesson learned is when we start the capacity building during the drug resistance surveillance, and then the lesson learned from COVID-19 pandemic, it helps us to build stronger laboratory capacity. And now we are in reforming for laboratory structure following the public health laboratory, where we would like to put the genomic sequencing for multi-disease in laboratory tier 4 and tier 5. So bigger structure reformation is underway. So I think we are really optimistic that in the future, maybe Indonesia can start, can implement as per our idea to start the TNGS-TB for clinical management in 2027 to 2029. Perhaps that's what I can share from Indonesia. Thank you.
Thank you very much, Regina. This is really very encouraging to see how you're well planned moving forward. I have two questions to you. One is these machines procured through the C19RM mechanisms? Are these dedicated TB machines, or are these more general machines under the public health network? That is one question. And the second question is, what kind of machines are you talking about? Is this nanopore sequencing, MinION, GridION, or Illumina? What are you talking about?
So from the C19RM, actually the machine is for all diseases, not only for TB, but TB become part of the priority disease to examine by these whole genome sequencing machines. And along with that, there are some funding from the C19RM for the TB sequencing. And for the machine that we have currently, we have three types of NGS machines. We have Illumina, we have ONT, and MGI. So for Illumina, I think we have like MySec, also MySec mostly, and NextSec 2000 we also have, and for the ONT we have Gridion and Minion.
Thank you very much, Regina, for this very precise information. I saw there's still the hand of Kristen. Is that a new hand, Kristen, or an old hand?
Yeah, it was actually a new hand. Thank you, Agnes. And actually, you and the previous speaker just touched upon it briefly already, because I just really wanted to emphasize that this technology of sequencing, of course, offers really a great opportunity to do multi-disease testing. And I think I would like to encourage all the countries to think about, indeed, especially those countries that are facing constraints with regard to finances, to really think about how can we work together with other programs in using this equipment and this reagents, maybe between programs. To make it in the end more cost efficient. So everybody thinking about cost and really keep in mind and emphasize that this can be used for multi-disease testing. That I just really wanted to mention that again. Over. Thank you.
Thank you very much, Kristen. And maybe there's one last remark I wanted to make on the types of machines, and maybe Regina, you can comment if you would like to add to that. But I think the Illumina machines, usually they are high volume machines, at least up until now, I think. Well, of course, the Gradient and the MinION are the smaller, the lower volumes machines. And the kind of the laboratory requirements, the capacity of the laboratory required in order to implement this technology, you can say it is at the level of the, for the low volume machines, is kind of comparable to what was required for the, in the earlier days, the second line Hain test, for instance. And that is the similar laboratory requirements which you need just for your thinking about if you can decentralize the implementation of next generation sequencing, which basically should be possible to a certain level. Is it also how it's used in Indonesia at the moment, Regina?
Yes, so in Indonesia, I think we have like a Novasex. It's one machines in the Ministry of Health, and we also have NextSex, and then also have MySex. Of course, the placement of these machines will follow which laboratory tier level. So the idea is we will have the bigger machine on the national level or tier 5. And then we will have like the NextSec machine in like the provincial level. And then we hope to have more on the ONT machines, which can be applied in more health facility level. So yeah, I think I agree with you, Ibu Agnes, that we need to design the type of machines, the load of the sequencing that it can run per day, and also you know, like medium, I heard it's more simple, and you can operate with battery, so it can be placed in the health facility or the peripheral level, or probably in like in Papua, where the primary care level is mostly needed. Over to you, Ibu Agnes.
Yeah, thank you very much, Regina. For now, maybe I hand over to Grania to close this session.
Yep, last opportunity for any other questions, comments. But otherwise, I think I want to thank everyone for yet again another very engaging session. Some of you on the front row will be pleased to hear that I'm not back this afternoon with my microphone. But I think we are continuing to sort of really pull out your experiences and your lessons learned, and I think your successes. And thank you, Regina, for sharing the bold plan from Indonesia and the experiences from Bangladesh and India. So we're going to end for lunch a little early, but you're not going to get extra for lunch, I think, because it'll give us more time this afternoon in the breakout rooms. So Mansa will tell me if I'm right or wrong, but I think the plans are the same as yesterday. So we can go up to the, are you going to give me a thumbs up? Thumbs up, same as yesterday? Good. So 18th floor, you'll receive your vouchers up there. So we're ending now at 1:45. So if we can be back here at, so we'll still take an hour. So if we can be back here at 1:45, that will give us a bit more time for the really important group work and the opportunity for kind of really digging deep into the country update plans. So 1 hour for those online, whatever time you're on, we're having lunch or breakfast or dinner, or depending where you are, for an hour. And we will look forward to seeing you this afternoon, and you don't need to run away from me this afternoon. Thanks.
in table 7. Will you move to 8? So PNG will move to table 8. So and Vietnam, so Vietnam is in table 3. Okay. Yeah, we can start.
So good afternoon. Good afternoon, everyone. Dr. Mansa has requested me and Lynn to chair this afternoon session. So my name is Mamel Calapio from KNCV. So we will be starting our plenary discussions in 5 minutes. Is that okay?
I would like to check if Indonesia group, are you ready?
So it seems like everybody's ready. So who wants to volunteer to do the presentation first? Oh, I see a hand and it's PNG. Jennifer, please.
Good afternoon. PNG is going to do the presentation first. We have 5 benchmarks that is not met. The 2 is for culture DST for the Iki Way. Currently, our culture facility is down, so we are not performing any culture activities in the country. We should recommence soon in Q2, this quarter. QMRL is our SRL, and the other ones that are our Iki provider. For our diagnostic, for the WRD, we have more than 5% error rate, and that's equates to the end user. So that's something that we will be addressing through refresher trainings. We will be bringing all the end users and train them, retrain them on sample processing. The next is the NGS. QMRL is the one that has been doing our whole genome sequencing. However, we were not requesting them to do the NGS, so that's something that we will discuss internally in country with our program team on the way forward for that. And that's something that we can do because DFET is funding that for us. The last one is line 25, the risk assessment for antimicrobial, the assessment. For us, TB, we don't have a document as yet. We just saw it now as a benchmark, and that's something that we will be working with our colleagues from the different unit under the same Central Public Health Laboratory. So we'll be working with them. They are public health microbiology section. So they're working on the AMR, and they have something in place, which we TB will see and customize to our program. Thank you.
Thank you very much, colleagues from PNG. So who's the next? Who volunteer? Okay, Vietnam.
So on behalf of Vietnam NTP, I would like to share with you some our not met situation, and we propose some action. The first one with the TB diagnosis algorithm required with the use of WRD as the initial diagnostic test for all TB presumptive patients. So in 2024, Vietnam already released a national guideline to recommend it to use the WRD as the initial diagnosis test for all TB patients. But due to the shortage of the WRD test, we are not able to cover all the TB presumptive patients to be tested with the WRD. For the proposed action, we are planning to allocate the other resources from the government through the health insurance. We're planning to the WRD, especially for the expert, will be reimbursed through the health insurance. And we try to allocate other external funding to procure more the expert cartridge for testing. And the last one, we also to use kind of patient pocket money the patient can pay the test by themselves. So the timeline in the 2026, we are planning to cover all 100% with the TB presumptive case will be tested with the WRD. With the second one, we have not met performance with the access the coverage access to the WRD. Not all the healthcare facility can able to accept to the WRD through the on-site or through the sample referrer. So right now it's only 20% the WRD tested through the sample referral. This is a limited the number. So we are planning to actually in the 2023 we already conducted the DNO to optimize the diagnostics network, and from that we are planning to deploy a digital platform to monitor and manage the sample TB referral network. So with the support from FI to develop the digital platform, and we in the 2025 with the support from the FHI with the training and technical support and the financial support from Global Fund, we are planning to deploy to scale up the digital platform for the TB referral management in scale up in national level. So up to the 2026, we hope that we can have a full functional of the digital platform for monitoring and manage the TB sample referral to maximize to coverage access to the WRD. And for the last one, for the access to the TNGS at the NTIL, yes, in Vietnam NTIL, we already conduct the TNGS for the routine tests, but only for the patient-based request, means that the patient pay the money for the testing performance. So right now we are kind of lack of funding to scale up the TNGS for the prioritized group, such as the patient with the BBR and BBM treatment regimen or the MDR TB case. So we are looking for the fund to allocate the funding from other partners to can be able to scale up the TNGS for the priority group. Yes, so that's all.
Thank you very much, Vietnam team. Who's going next? Colleagues from Indonesia.
I'll represent on behalf of Indonesia. So for our laboratory, we still have a number of unmet in benchmark. The first one is for the diagnostic algorithm. So currently for the expert and brief guidelines in 2020, we already included the stool sample as an option as for the specimen sample. We have already have a circulate letter drafted and circulated in labs in Indonesia. However, the sputum and gastric lavage is still the main specimen for expert test in Indonesia for children. In child and adolescent TB guidelines, we already have it last year. The stool and alpha has been recommended, but yet to utilize. And the use of LF-LAM in PHLIV will be implemented this year. And the SOP and guidelines has been drafted and still now waiting for the procurement to take place. However, in 2025, we still focus on the implementation in the priority TB HIV district. So as I said before, this year the NTP are planning to train for the LF-LAM in 29 TB HIV district, priority district in Indonesia, out of 38 districts, out of 514 districts. And the next one is for the culture DST EKA. In Indonesia, there's 92% culture and DST TB laboratories plus last year for the EKA cycle. And this is not met, and the NTP plan to have capacity building and monitoring and evaluation lab on the EKA part, and also improvement for lab infrastructure. The next one is for the TB laboratory quality management system. For now, we haven't any data on this, but this is on discussion in the NTP, especially for the lab team. The next one is in Indonesia, there's only 95% functional diagnostic instrument that have error rate less than 5%. So same as the previous unmet criteria, the NTP are planning to have a capacity building and improvement for the lab infrastructure. Oh, this one also for the laminate. So in Indonesia, we don't perform the laminate phenotypic DST because the pure substance is unstable. So we have to omit it from the DST, phenotypic DST testing. For the use child and friendly diagnostic methods for stools, we don't have it in all laboratories because of the supporting equipment like BST or biocontaminant centrifuge. This is required for the testing. So only few labs that can do it, especially in bigger center, in big cities such as Jakarta or Bandung. And the last one will be, that's the last one actually, Mono. Thank you.
Thank you, Indonesia team. We give them a big hand, please. So who's going next?
Yeah, Bangladesh.
Bangladesh.
Yes. Thank you. Welcome to you all to the planning for National TB Lab strategic plan updates in case of Bangladesh. You see, in most of the cases, actually, in Bangladesh, we achieve or meet the benchmark, such as in TB diagnostic algorithm that require WHO recommended diagnostic tools, and in most of the cases we use these tools for TB, all TB presumptive, and in all primary healthcare facilities we use expert lab, and there are 150 union lab health facilities situated at below sub-district level, and all the individuals with TB, they have the access to WRD as the initial diagnostic test, and approximately 75% of MWRD labs are they are capable to doing this. They're providing these facilities actually, and in most all DRTB treatment initiation center have access to DST for rifampicin and for linezolid and fluoroquinolones also, but we didn't meet all DRTB treatment initiation center have access to DST for beta-quinoline and delamanid and so there are 6 reference lab have the capacity for phenotypic DST of beta-quinoline, and samples of all rifampicin resistance must be sent to reference labs for PDST. Some technical issues are there actually. So in case of delamanid, we have that 6 reference labs that have the capacity, but samples of all rifampicin resistance must be sent to reference labs for PDST. So the actions, agreed actions actually in that cases, there are some technical issues. So NTP Bangladesh is trying to solve those issues, and we are trying, and the government support is also necessary in these cases. So that's one of the challenges for us. And access to TB whole genome sequencing is available at NTRL, but the benchmark is not yet introduced under NTP Bangladesh, and also for the TB targeted next genome sequences, and these 2 TB WGS and TB TNGs, these are not met in case of Bangladesh. Actually, WGS or TNGS is in NTRL with the support of USAID funded IDDS project, the actions, agreed actions, and NTP is trying to explore different options for implementing these techniques, molecular techniques in case of Bangladesh. And in case of antimicrobial resistance, risk assessment policies and research are they are not in place at this moment, and hopefully we will try to introduce it and try to input, try to make the guideline so that we can implement it in our country. So that's from our part. Thank you very much.
Thank you, Bangladesh team. Any volunteer for the next? Cambodia.
Good afternoon. On behalf of the Cambodia team and then our IT, we like to present about the result discussion. We have 6 not met based on the benchmark. And also the one thing, the first that about the diagnosis algorithm, including the LF lamp. We are using that from the fund support from NAP, from 8 program. The algorithm still standalone, not included in the 4 national program. We will revisit it. We give them the guidance for that. So we can say MET because we are using the lamp as the diagnostic test for the advanced HIV patient. And the not met one that the percentage of the laboratory to have the QMS, we have around 80%, not 100%. As you know, the lab TB lab is the part of the general lab in the health facility. The some lab TB lab not just have the system there, some part. That's why we say. And also for the drug resistant, we have if we consider the gene expert as the DST, let's say reform vaccine was 100% cover, but for linezolid, bedaquiline, and delamanid is not there. But we do our contracted with the IPC, Institute of the Pasteur Cambodia. We have contract, and then for those who have the presumptive MDR, or resistant, we send them for the test. So this is a partial, but it's not in the program yet. And also for the sequencing, the whole sequencing or target new generation, we have not yet implemented. And we are concerning about the human resource, about the facility, and also about the funding. And also consider also the cost effectiveness, as the Cambodia is not the high burden of MDR. We have very, let's say not so many, around 100 or 150 something. The case is not so many. So we think about how the cost that we procure the machine and then so on. So contracted with the IPC would be the best way. But at the same time, for the time being, we may plan with the partner. But unfortunately, the USAID was ended the suspend fund, something may be difficult. So these are our consideration. So it is end from the Cambodia side. Thank you.
Thank you to the Cambodia team. So IPC is Institute Pasteur. It's the private lab in Cambodia. Okay, thank you. Next. Lao PDR, please.
Good afternoon from Lao team. For improve the and implementation WHO guideline, Lao have 2 points for introduce this meeting. The first is the capacity building and regular monitoring, because in Lao PDR have 24 gene expert site per 164 lab unit. So we use the system transportation for send the sample for diagnostic. So we have more than 5% error. For strengthening this point, we kept the training for the lab staff and supervision, and we have planned for the using the digital tool to monitoring for reduce the error rate. Second point is about the NGS and home genome sequencing. In Lao cannot do this technique now, but we have collaboration with the Supralab, is the KIT from Korea. Many things that the Lao cannot do by ourselves, that need the help from the Supralab, like media for the DST, and about the quality laboratory, and QC for the microscope gene expert, because now we have just only QC QC for the ST. So many things to need the help from Supralab. Yes, thank you.
Thank you very much, Lao
Anything my
PDR
boss do.
team. We only have 3 countries left, so I would like to start. Mongolia.
Good afternoon. Mongolian laboratory network and diagnostic capacity quite nice, and we implemented all WHO policies and new methods very rapidly, but in the future we need to focus on implementation process. Now we have two challenges and gaps. TB diagnostic algorithm requires use of VRT as the initial diagnostic test for all patients with some pulmonary and extrapulmonary TB. And current situation, cumulative number of HIV cases in Mongolia, almost 400 people live with HIV in Mongolia. And in last year, we detected 19 new cases with HIV out of 45 estimated cases, and more than 97% of cases coverage of retrovirus treatment. And each year, approximately 3 to 5 new cases reported among living with people with HIV and diagnosed with tuberculosis and enrolled in anti-TB treatment. The TB care guidelines included LAM test, but currently not yet implemented in the routine diagnosis. And we are planning and conducting implementation study to evaluate of performance among people living HIV using the LAM test, which is planned to be completed in the Q3 in this year. Based on results of the evidence, we will implement the routine diagnosis for LAM. And next, easy to use child-friendly diagnostic methods are available in all TB testing laboratories. This is includes TB national TB guideline, but it's also a study on stools for diagnosis children TB is ongoing, and we will complete also this year. And we are preparing to conduct a pilot study among children and adults who also with living HIV, which is also scheduled to be completed in the study. Thank you.
Okay, thank you very much, Mongolia. Big hand. May we call on
for Thailand. Thailand met equal unmet 10 and 10. We have a lot of unmet. The first thing is about to access primary health care, because in Thailand, the facility that provide treatment and diagnosis for TB is at level of hospital. What we are going to do is to decentralize the system and to approach a more primary care. And for the all TB that access to molecular recommendation, visual recommendation, diagnostic test, we are not met yet. We are going to use our domestic funding for the testing. So the expert is too expensive for us. Thank you for putting for information that maybe we have another alternative, maybe from China, that we can more possible to buy. And for the laboratory, we can do 77% of the patient with be positive to confirm with the DST and rifampicin and fluoroquinolone is no problem in Thailand, but bedaquiline and linezolid, we do the DST at the NTIL level because we have only about 50 cases of pre-XDR per year. So we centralize all specimen to the NTIL. We not distribute this to the remote area. And for the Delaminic, we just received the powder of drugs just on November or December. So this is on the second round of the validation in the NTIL, including pretominic. So we are going to do the DST at the NTIL as well. And for the EQA, we do for all private and public in Thailand, or almost about 20 or 30 lab that send to us, and also all lab in Thailand pass the ISO or LA laboratory accreditation already. The other not met is about the children. We are working with the Pediatric Infectious Disease Society of Thailand to do the policy together, because as I mentioned in the previous, that in Thailand we have some of situation that we didn't use the stool exam for expert in the initial diagnosis, and we are working with that society to encourage the doctors and also the lab to use more. Thank you for Thailand.
Thank you very much. Big hand for Thailand, please. So last but not least, may we hear from Nepal?
Thank you. So for Nepal, we are using MWRD as the initial diagnostic algorithm in our guideline, but not using the LF-LAM because we are a very, very low burden for HIV, and it is indicated for the HIV positive only, that's why. And not all primary health facility has access to MWRD. Definitely, there are so many primary health facility, but they have a linkage with the courier facilities, like a sample transportation is available there. Not all individuals, but 65% had access to MWRD as an initial diagnostic test. And we have two culture DST laboratory, and both are taking part in the EQA every year, and both pass the EQA every year. But last year, due to flood in Nepal, they have not taken part, but now again, they have started their work, and maybe this year again, they will pass the EQA. For quality management systems, yes, there is the quality management systems, but it is difficult to implement at the peripheral site. So there is not met, you can say, partially met or not met. And all functional diagnostic instrument has less than 5% diagnostic error that is achieved. So 100% achieved. So that is met, I think. Not all, but 80% of the bacteriological confirmed TB undergo the DST. So not all, but 80%. So not met, it comes in the not met. Yes, all DRTB patients treatment initiations, SS2 DST for reform patients. Definitely all the DR centers have the gene expert machines which can test for the reform patients. For linezolid, bedaquiline, and Delaminic, definitely all the DR treatment centers has a link with the culture DST lab, and they can send the sample there for testing. So they have, so it is completely met. For child-friendly diagnostic method, it is available at all the diagnostic sites. But for priority, definitely it is prioritized. If the patient cannot produce this sputum or respiratory sample, then only we prioritize for them as a stool for the primary diagnostic sample. Whole genome sequencing is not available at NTRL. It is available at the NPS, National Public Health Laboratory. And targeted next generation sequencing is not available at NTRL. All TB lab achieve turnaround time within 48 hours. And antimicrobial resistant risk assessment policies and research is not available in Nepal till now. That's all from Nepal.
Thank you very much, Nepal. So we've heard from all the countries. So we heard some common unmet items among the benchmarks for diagnostics. We also heard some unique ones. One thing I'd like to flag is there are some countries that have been affected by the USAID budget cuts, especially for targeted NGS. I'd like to flag also that the Philippines, although they're not here, we're also affected by that. We were ready to implement it with USAID funding, but it's not going to materialize anymore. So, any questions? Yeah.
I'm not sure if you have any questions to the country team. We don't have a much time, but we can take a couple of questions.
Yeah, if I may, I think if I heard you well, Amamel, you were asking if countries may not be able to implement the plans as planned because of recent funding constraints, the cuts that happened around the world.
Yeah.
So can each of the countries answer that question? That would be helpful, I think.
Yeah, I
Can
think
we start?
And so the plans, as you have now presented them, are these realistic, given the fact that some budget cuts occurred?
Actually, they plan just join this important workshop, and then we do not have the realistic plan to submit or to negotiate with any partner when convince the government to do that. I think that if possible, we may bring that the new recommendation from here, and then to the country and discuss with the among the decision maker at the program, and then we push this one, and then we see whether the budget will come to support or not. As I told you, that Cambodia is not the MDR high burden country. The case is not so many. That's why it's a bit difficult to answer this one. But we know budget is the constraint. As Mamel say, we have the support so far around 1/3 with USAID, and then about the cut, so it's a big question for program as well. Yeah, thank you.
Thank you. I see the headphone.
Yes, thank you. For key forwards of the implementation, I think it's Laos is really similar to Cambodia. One is we based to the maybe it's not higher than MDR or RR in the country, and second is because of a funding source is limited. For example, now we have like a common theory to support, but in the country that's we don't have any set of donors. In terms of capital domestic funding, it's really limited and not in time. So in the key forwards for TNGS or whole NGS is we have to discuss more. But anyway, we discussed with the KIT, Korean Institute of Tuberculosis, that we plan to focus for some, maybe in the end of the year, it could be start for some, yes, that's all from Lao team.
Thank you. Anyone else, maybe Vietnam team, you want to speak about that?
Đâu mà lại em xin phép nói tiếng Việt này cho các bạn Hương sẽ dịch. Và với cái kế hoạch của bọn em thì đang có 3 cái điểm nát mét, thì như vừa nãy Hương có trình bày, thì trong cái phần này thì những cái phần action này thì nó đã nằm trong cái kế hoạch và chúng em cũng đã triển khai một phần. Vậy nên là cái việc mà có thể thực hiện được hay không thì nó cũng rất là khả quan. Và thứ hai nữa là những cái phần mà liên quan đến kinh phí thì cũng đã có những cái kế hoạch kinh phí để có cái sự đầu tư nhất là của Global Fund cũng và tuy nhiên là để có thể đi được đến
đến cùng với tất cả những cái kế hoạch này, và để cho nó có một cái hiệu quả tốt nhất có thể thì chắc là cũng cần một cái sự nguồn lực, có một cái sự hỗ trợ về mặt nguồn lực sẽ phải rất là tốt, và cùng với sự chung tay của rất là nhiều đối tác, cùng với lại sự hướng dẫn của WHO, thì chúng em nghĩ rằng cái kế hoạch của mình cũng sẽ tốt ạ. Và nếu như mà có một cái khoảng thời gian nào đó nó nhiều hơn thì bọn em có thể nói kỹ hơn và có thể giới thiệu được nhiều hơn, để mình cũng để cho các đối tác cũng như là WHO cũng có thể biết được chi tiết hơn về những cái kế hoạch mà bên Việt Nam có vừa mới đưa ra ạ.
Just now we have 3 major items, so we propose several action. Actually, this one we consider is feasible and actionable to be implemented in the near future. But the main barrier for us is the funding. Right now our main funding is from Global Fund. So we are also trying to find another way to allocate another resources to can sustain our activity in the long term. But I think that we can together with other partner, with the government, so we can reach our goal. But due to limited time, we cannot say much more in detail for our plan.
You Vietnam team, Indonesia want to.
So for us, Indonesia, TB is still the priority program for our government, especially for the president. So yeah, there's some obstacle in implementing some activities, but for the essential part, as for like diagnostic services and drug procurement, it can be fulfilled with our domestic funding. As for most of the activities like monitoring and surveillance, previously we can do it offline or site supervision. For now, the capacity building or the monitoring, we do it via online meeting. So
Thank you.
From Bangladesh, we know the USAID support is withdrawn from the Bangladesh side, and the USAID contributing with lots of activities in Bangladesh in TB response, like through ICDRB. They contribute to the active case findings in the hospitals and the child TB detection. They support us in the child TB detection responses also, and they also contribute some research programs. They support us with technical assistance in the National Tuberculosis Control Program, and also they contribute to scale up the ultra-portable X-ray with AI supported in the whole of the countries. These supports are stopped now. Our government is increasing their domestic fund to roll out this type of activities. And also, you know, the Global Fund is the major contributor of the TB response in Bangladesh. That's why we request and send a budget to the Global Fund to support this type of activities also. I think some rearrangement already done regarding these activities, and training and the capacity build-ups which are contributed by the USAIDs. Now it is contributed by the domestic funds. And I think with Global Fund, other donors and government are contributing the other programs that are supported by the USAIDs, and that's why we are overcoming the gaps which is situated due to the withdrawal from the USAIDs. Thank you. Thank you for Bangladesh.
Thank you. PNG.
Once again from PNG, USAID for the TB program, USAID is not really supporting. Like for the program, it's they are supporting the HIV side. So for us in TB, yes, as like many of the countries have mentioned, our domestic funding is a challenge. So we are really supported by Global Fund and the Government of Australia, the Fed. So they are the ones that are supporting us, and also the technical support from WHO. So those are the main partners that we really work with. Bennett is there for us. They are our implementing partner as well. They secure funding and they help the program to implement. For the laboratory side, the government of PNG is paying for all the reagents like the culture and all that. The government of PNG is supporting us with that, even the drugs. The drugs also, the government of PNG is supporting. So the other, the procurement. So the other activities like supervision and training, those are the areas that we seek support from Global Fund and the FED and other partners that are in country that we do our plans and send to them for them to support that gap. So with the USA, it's really for the TB program. Yeah, Dr. Lindy is there. We don't get a lot of support from them. So in terms of sustainability of the program, we see that we can do it. It's just that we need to strengthen and find possible ways on how we could address the challenges that we are going through. Thank you.
Thank you. Mongolia.
Yeah, in Mongolian situation, domestic and government fund supported almost 70% of national TB program budget, and 30% of funds supported by Global Fund. And also we are implementing and collaborating research projects with supported by JICA and COICA. And last year, Mongolian government approved public health law. It was very first time in Mongolia. Then we developed a public health services package, and our government currently in Mongolian health sector supplied health insurance, supported only health service. Yeah, healthcare service, and we don't have any more budget for public health service. But we hope next year our government and domestic fund will be support public health service. Then we can transit to domestic fund step by step. Currently, we have Global Fund support end of 2030. Yeah, last year our government contracted with Germany government. This contract focused on deaf to health project. Yeah, then we have 30% of foundation by Global Fund.
Thank you. Now I move to Thailand and Nepal.
Thank you. Thailand is in the transitional stage from Global Fund funding to be 100% domestic funding, because Global Fund already signaled to us that they will not support us anymore since from the next 2 years. So this is one of the challenges of Thailand, that if we plan, then we have to monitor and evaluate very closely that if the funding is not more from Global Fund, is that how possible to do as according to the plan. But even if no funding from Global Fund, we still have some domestic funding that I believe that should be enough. But however, the plan that the international standard or global standard that guideline by WHO maybe not fully aligned with Thailand's specific situation. For example, for the children, in Thailand, we work together with the Pediatric Infectious Disease Society for many times, and they strongly believe that TB situation in Thailand children is very, very low. So almost all TB patients will be diagnosed and treated by pediatrician only, and they use many way to diagnose them, even clinical diagnose or X-ray or do the CT. So maybe they not just depend on the expert or molecular test. They can treat and try the treatment by themselves. So that's why they maybe not believe in stool exam if that will cause trouble with the machine, because we have machine from Global Fund and we cannot lose it now. And all the other thing like the rifampicin resistance, that in the guideline, situation in Thailand is now we are more serious with INH resistant. So maybe we have to shift not only rifampicin resistant for be the first DST that we are going to test, we have to be shift to be both drugs together at the same time, and it should be at the point of care as well, because we cannot go back to the patient asking for more sample to do another test for INH only. But if we use the expert XDR, is too expensive for us as well. So maybe we have to use the conventional PCR, but the other thing that we can detect both rifampicin and INH, not at the point of care, but maybe near point of care, and then we can transfer the specimen from the small hospital into the bigger hospital that has this machine. This may be possible. So just wait and see what Thailand can do after Global Fund. No more. Thank you.
And Naveen. For Nepal, we do not have USAID support for TB program. So we are lucky, at least. So we have the Global Fund support, and it is for next 2.5 years still for this cycle 7. So we are safe for 2.5 years. Maybe after that, we don't know what will happen. And government has around 80% of the funding of total NTP budgets. 20% is from the Global Fund. Most of the medicines are procured by the government, like 80 to 85% medicines are procured by the government of Nepal. And in diagnostic kits like a cartridge, around 50% is procured by the government of Nepal and 50% from the Global Fund. Other programs are also supported by the government of Nepal. So this is the overall funding situations of Nepal.
Okay, thank you very much to all the countries who shared about their financing situation. So it's quite interesting to hear different situations. So with that, with Lynn, we're closing the session on TB diagnostics. And then moving on to another interesting session regarding the WHO policy updates on TB and undernutrition. Before that, we do have a coffee break. And can we have 15 minutes for that? Let's be back at 4 o'clock. Yes, have a big hand for the session on diagnostics.
There we go, that's it. Okay, fabulous. How do you do it? Oh, so I put it there? Oh, I see. So, okay, I'll try.
Hello, everyone. Can we start? So maybe before we start the next session, we would like to congratulate the diagnostic session, especially Patricia. Very excellent session. And yeah, and all the presenters and group work and discussion. And now we move to the another.
That's okay. We've got an empty room now. About the end of tea break. Is that bell the end of tea?
Yeah, so now I like to introduce the next session on the WHO policy updates on TB and undernutrition. And the first presentation by Annabelle about policy updates.
Okay, thank you very much. So if I can get this right, hang on a minute. This is, I'm doing this backwards. Hello, what's happened? Oh. Okay, that's it, fine. So next, there we go. So last year's interagency report on food security and nutrition in the world estimated that more than 700 million people faced hunger in 2023. That's 1 in 11 globally and 1 in 5 in Africa. I'm afraid I can't give you the numbers in your particular regions, but the situation globally is unlikely to improve in the near future. So the Global TB report last year estimated close to 1 million people, or new TB episodes, were attributable to undernutrition. And you can see in the map here the sort of hotspot countries where undernutrition is one of the main drivers. The Cochrane review came out with a systematic review last year, which was commissioned by WHO, which estimated that undernutrition more than doubles the risk of TB. And a systematic review by Lee et al. Estimated that about half of people with TB had undernutrition. So we know that undernutrition is associated with poor TB treatment outcomes, including death. And you can see here in the table that from a study from Sinha et al. That unchanged or decreased BMI after treatment initiation had a 5-fold risk of mortality during TB treatment. Conversely, the nested cohort study in the rations trial by Bhargava et al. Found that weight gain during the first 2 months in particular was associated with considerable reduced mortality. So we can see that there's a very good interaction between the two, and we can see that there's really undernutrition is an important predictor of mortality for TB patients. And we know that TB worsens undernutrition and actually feeds undernutrition. And we know that also patient cost surveys, that there's a high proportion of catastrophic costs that are spent on food. So there's a really nasty, vicious cycle going on between poverty, undernutrition, and TB. So going back to the global, the NTB strategy, TB and comorbidities fit very firmly within Pillar 1, but of course, Pillar 2 is absolutely crucial for bold policies and supportive systems, as is intensified research and innovation. And at the UN high-level meeting on TB in 2023, member states committed to assuring integrated care for TB and comorbidities, as well as determinants such as undernutrition, and even also putting together bold national strategic plans in order to assure that access. So in 2013, WHO came up with a guideline for TB and undernutrition, which you will know about. And since then, new evidence has been evolved on the interventions and micronutrient supplementation for people with TB, as well as interventions or food assistance for households of TB for TB prevention. So WHO commissioned 3 systematic reviews on the 3 PICO questions relating to nutritional interventions for people with TB, micronutrient supplementation for people with TB, as well as food assistance for household contacts. And we also commissioned surveys amongst Ministry of Health representatives, some of you may be in the room, as well as TB survivors and their families on acceptability and feasibility of nutritional support. And the GDG, Guideline Development Group meeting, was convened in June, July last year to formulate the recommendations. So for PICO 1, the nutritional interventions for people with TB, the systematic review identified 18 randomized controlled trials with quite a big sort of array of interventions, which also measured a different array of outcomes. So it's actually quite challenging and not possible or rarely possible to do any meta-analysis. So the GDG really had to look at the data and see what worked. So for the 4 interventions, green tea extract, fish oil, Chana strata, and dietary nursing, the GDG judged that the evidence did not support the provision of any interventions for people with TB, as the balance of effect for the studies was uncertain, low certainty of evidence, and very limited impact. Whereas for arginine, high energy protein supplements and financial support and psychosocial counseling, as well as food vouchers, the GDG judged that probably the balance between benefits and harm favored the interventions. And here we have, on this slide, you can see the interventions and the outcomes which the studies looked at for the particular interventions, the study authors, as well as the effect size and the certainty of evidence. And all of these, you can see that the effect size is going in the right direction, except for one, which is the Martins trial, which on adherence, unfortunately, they requested that the patients during the intensive phase come into the health facilities and eat their meals in the health facilities on a daily basis. And not surprisingly, that did not work for adherence. So the GGG recognized that that was actually design implementation was at fault, and it wasn't to do with the fact that there was no impact. So it was more a case of, the importance of how the intervention should be. For micronutrients for people with TB, the systematic review came up with 33 randomized controlled trials for vitamin D, vitamin A, and selenium and zinc. And it came up with 17 RCTs for multiple micronutrients. And for vitamin A, selenium, zinc, and multiple micronutrients, the only benefits that, according to the critical outcomes that the GDG had pre-selected, was an increase in serum levels. So the GDG felt that actually these micronutrients did not warrant recommendations. It wasn't appropriate. Except for vitamin D, there was probably the balance of benefits and harms overall favored the intervention. So looking at the vitamin D evidence, you can see there are two trials for TB cure, which the GGG really focused on. Both trials were very different in their approach. One trial looked very much at, they had different dosages, and one trial looked at people who were vitamin D deficient, and the other trial was in an area where there was high prevalence of vitamin D deficiency. So there are a couple of unanswered questions there, but no adverse events and increase in change in serum vitamin. And then for food assistance, which actually was the systematic review identified one randomized controlled trial, which was the rations trial, which was conducted in India by Bhargava et al. And this found close to 40% reduction in TB incidence amongst household contacts who received a food basket and multiple micronutrients. So a big impact, and the GDG recommended that, that this obviously favored the intervention. So these are the recommendations that are coming out. The process has gone through the guideline review committee, and we have just received the go-ahead to move forward. So the first recommendation is on assessment and counselling, and this has actually been adopted from the previous guidelines from 2013. Now, the evidence on assessment and counselling was not clear in terms of there was no evidence, and there was no evidence in 2013 either. There's indirect evidence. There is evidence that counselling improves nutritional outcomes in other populations. And of course, if you identify nutritional undernutrition due to nutritional assessment and you provide the interventions, and those interventions result in better outcomes then. So the GDG felt that this was very much a good practice recommendation, and actually, it should be done. For household contacts of people with TB, there's a new recommendation, assessment and counselling. Before it was screening and assessment for undernutrition. This adds the sort of element of counselling along with contact investigation. So as part of contact tracing, assessment and counselling should be conducted. And then a new recommendation, which very much simplifies the old recommendations. Anybody who has undernutrition, in other words, with a BMI of less than 18.5, should receive nutritional interventions. And then in settings, this is another new one, in settings with food insecurity, similar to the situation in India, food baskets in combination with multiple micronutrient supplementation should be provided to households of people with TB, and that includes the person with TB. And then a new recommendation, now this is a recommendation on vitamin D supplementation. Because of the unanswered questions, it may be provided to people with TB in the context of rigorous research. So the guidelines will also tap into existing recommendations from other guidelines because they relate to TB and undernutrition. So that's the two recommendations that Cecily came up with yesterday on TB screening in people with risk factors in contexts of high TB prevalence. So that would be nutrition as a risk factor, as well as TB screening amongst subpopulations who have structural risk factors, and food insecurity is one of those risk factors. And then there's also the treatment adherence interventions from our treatment and care guidelines, which is regardless of nutritional status. So for key considerations, I think Arvind Betaguri from WFP will be adding some more to these. But of course, multi-sectoral engagement will be critical for this throughout the sort of programming, from planning to monitoring and evaluation. And countries will really need to work with stakeholders in terms of mapping food security, understanding the landscape. Equipment will also need to be procured and put in place in some of the health facilities. So studies have found that not all TB facilities are adequately equipped with the relevant equipment. And then models of delivery will need to be decided upon. You know, will the assessment and counselling be conducted in the health facility, or will it happen in the home? And of course, training and SOPs should be developed. And for assessment, also looking at the reasons for undernutrition, maybe Helminth infections, as well as counselling content. And something that's quite important is the framing of interventions as nutritional interventions as a medical intervention. It's very much seen as a sort of an optional add-on to TB care. And I think this is really important when we think about, a lot of the studies came up with the issue of food sharing within the family. And so the person with TB will need to understand that actually this is in order to make them better, and also for the family. And then in terms of the food interventions, the nutritional interventions and food assistance, these will be needed to be tailored according to the level of undernutrition. So for instance, if people are severely undernourished, then they might need ready-to-use food, or if they're mildly undernourished, they may need a bit of food supplementation, and that needs to be decided. Also, the options now are, maybe vouchers are the idea, or and it may be, if you're working with stakeholders in the field, that it may be that transfers are the way that it's done. And so this needs to be discussed. And of course, there's also the people-centered delivery. We don't want to demand that people with TB come to the health facility and receive their food there. It needs to be convenient, and also minimizing stigma. So this is the conclusion. It's well documented. We've got the upcoming guidelines, which will require serious partner engagement and multi-sectoral collaboration. And we are going to be, for the guidelines will be coming out very soon, in the next couple of months, hopefully. But the operational handbook, we will be actually having a further consultation, and we'll be looking to you, to countries, because I think the implementation of this is going to be the most important, and it's going to be the most challenging. So I would be really interested to hear your feedback today and tomorrow as we go into group work. Thank you very much.
Thank you very much, Annabelle, for that very interesting update on the WHO guidelines on TB and undernutrition. I'd like to open the floor now for any questions that you may have for Annabelle.
That's enough. Good.
If not, yeah, we can open the floor
I'm happy
after
to answer
the
questions later on.
yeah, after the 3 other presentations. Thank you very much, Annabelle. So next we're going to have a presentation from the World Food Program from the Regional Office for Asia and the Pacific. And we're going to hear from Arvind Bettigeri. I believe this is a recorded presentation. So can we play that now?
or have not been keeping well for the past 2-3 days. So apologies for my voice if it is a bit hoarse, but I'll try my best to to present what we are supposed to today as well. So basically, before we get into the overall presentation on practical implementation considerations, it is important to look at the overall nutrition landscape to begin with, because within the overall nutrition landscape is embedded the issues of why it is important to make TB programs nutrition sensitive. So in today's presentation, what I will try to do is basically look at the nutrition situation in the Asia Pacific region. Try to look at what are the kind of interventions that are available, and then also talk a little bit about what WHO and WFP are trying to achieve in partnership in relation to this TB and nutrition integration. And then I will end with some key thoughts in terms of what should be the next steps as well. So let me begin by the nutrition slide, the nutrition challenge in Asia and Pacific. You are all not new to this slide. We have countries which are high on stunting, high on wasting, and then we also on the parallel also have an overweight and obesity epidemic as well in the region. Now, when you look at this nutrition challenge, and then when you look at this map, and then when you try to embed this map or layer it over the TB occurrence map or incidence map, you will find pretty much similarities in terms of the high burden countries also have the high nutrition challenge as well in terms of micronutrient deficiency, malnutrition, stunting, wasting, whatever the case might be. Now, this is a no-brainer. I mean, as we know that undernutrition is a major risk factor for TB infections as well. But important to understand both spectrums from the nutrition side as well as from the TB sides as well. It's important for us to understand this particular issue. Now, at the crux of all this is something called the access to healthy, nutritious diet, which is a key driver for the nutrition challenge as well. Why? Because the region has the highest number of people worldwide unable to afford a healthy diet, which is close to 1.6 billion people. Now, what impact it has? What is the cascading impact of that? is certainly if the families and individuals are not having access to healthy diets, then that has a direct bearing in terms of the individual and the household's nutritional status, thereby precipitating the process of them becoming at high risk for TB infection, either in early life or later life, whatever the case might be, depending on the circumstances and situations as well. And then, on top of that, 77% of children, young children in South Asia are not meeting minimum dietary diversity. 38% consuming 3 or fewer food groups daily. Now, this is important statistics because the point is that in this statistics itself is the whole story about why TB programs have to be nutrition sensitive. I'm trying to look at it from the nutrition prism in terms of why it is important. I mean, we have talked about from the TB prism, but also from looking at it from the nutrition prism as well, because it affects the overall community at large at some point in time. The other aspect, which is the most important aspect, which we have to also understand and also leads to the urgency of us addressing the nutrition issues in TB programming as well, is that malnutrition costs the global economy USD 3.5 trillion every year. That's the cost of inaction. That is how much it is costing us. In Asia, impact of undernutrition is estimated to range from 4 to 11% of GDP in terms of the human capital development cost that has been lost. So I think these figures should give us alarm bells in terms of how urgent the issue is in terms of trying to address that. Now, in the overall scheme of things as well, now when we are saying 4 to 11% GDP, I mean, like, if you add the other program, public health program cost as well, I'm sure this number will go up as well. So it is important to understand it is not just about the treatment and prevention of the household incidence of TB or trying to address the issue at a larger household and community level as well. It's also directly impacting the economics of the nation as well, which is very critical. And I think in our policy discourse, and I have been talking to some of our colleagues in WHO as well, is that in our policy discourse, I think we should bring about more and more costing discussions because the policymakers understand the language of cost and the policy implications pretty well. I mean, having worked in the government myself, I can tell you that, the moment you bring the cost argument in terms of what is the cost of inaction, how much is the country losing in terms of economic impact, then you basically start getting that attention as well. Because whether you like it or not, the decision maker, the holders of the finances are the Ministry of Finance. They're non-technical people. They need to know, okay, if I don't act, what? I mean, I have competing resources. The social welfare is asking me money. The labor department is asking me money. Health department is asking me money. I have only this much part of money, which I have to distribute among different ministries as well. Where do I bring the resources? So what we have to do is up the game in terms of not only bringing the clinical public health angle, but also the economic angle to this. And I think that would up the ante in terms of our policy advocacy discourse as well. And I'm glad that WHO is working on that, and WFP is more than happy to partner with WHO on this particular initiative as well. And I have spoken to a few colleagues in WHO as well, as this is something which we should be looking at in terms of studies and doing some kind of an economic modeling as well. We have done that for the food assistance program, which is great, but also looking at the overall economic cost as well. We have some studies that have been done for the nutrition pieces. We can also see if that can be extrapolated to the TB programs as well, with certain modifications, and whether a model can be brought about to basically bring the gravity of the situation to the policymakers' attention. Now, why TB and nutrition? Again, you are you know this, so I will not spend much time on this particular slide. And it's the most significant social determinants for TB in the region as well. As I mentioned, 357 million people in Asia couldn't afford a healthy diet. And this is also an important element that we have to keep in mind, and speaks the urgency of looking at nutrition sensitivity of TB programs as well. And then nearly 48% of the people globally are undernourished as well. And then the other undernutrition increases the risk of TB occurrence and other things as well. So I will not spend much time on this slide. It's a no-brainer. It's quite clear as well. Now, looking at importance of nutrition support in TB programs, we have the latest rations trial, the modeling study, which has given us a nice indication in terms of how nutrition support basically helps in TB programs as well. So, and also the WHO guidelines is talking about that as well. So what we need to do is that take this, whatever evidence we have, to the next level and see how we can amplify that with certain operational models of, okay, there is a ration study, there is a modeling exercise, there are WHO guidelines. What could be the potential operational models as well? Because it's one thing in terms of in a concentrated geography to do a pilot project or a small concentrated project, but it's a completely different thing to operationalize this as a policy guideline, as a policy initiative at the national level involving the entire population or a significant chunk of the population. Now, we do have some operational models in use, which is the India fortified rice. India is basically looking at that model as well through the Nikshay Poshan Yojana. It was just started last year, November. So we'll have to see how the benefits of this program percolate down and what we learn from that. I'm sure WHO is looking at it, excuse me, looking at it and trying to see what learnings can be incorporated from that. And then you also have some conditional cash transfers linked to tuberculosis treatment and nutrition in Indonesia as well. But these are scattered operational models here and there. What we need is a solid demonstration involving multiple countries and trying to see how we move forward. Now, there are challenges related to this because, when you look at South Asia and Southeast Asia, South Asia has a huge social protection, school meals, and social welfare, food assistance, in-kind assistance programs whose footprint is pretty huge in most of the countries in South Asia. When you come to Southeast Asia, the only social protection footprint that we are looking at is basically school meal program. That's the only social protection footprint. There are certain other vulnerable groups that are provided with cash, but not in-kind food assistance as well. Now, cash also, we will have to study that because, people's nutrition-seeking behaviors are very different. So there's a lot of scope there in terms of trying to understand in terms of, okay, if we are transferring that cash, how that household is using that cash in terms of seeking nutritious and healthy foods for themselves and their families as well. So there is one proposed project that we are trying to look at this aspect is the integrated approaches to enhancing TB management outcomes and reducing the TB burden. And which is the addressing the bidirectional relationship between TB and nutrition in the Southeast Asia region. So this is a collaboration that WHO Southeast Asia Regional Office and WFP are working on. This is a proposed concept. It's a proposal that we are working on, and we are hoping to launch this project in the near future. What we are looking at, basically the aim of this particular project is to address TB outcomes and household vulnerabilities together, and this is the first time, and we are making an attempt based on whatever findings we have seen and whatever learnings that we have had on the operational models and the ration study and the modeling study as well. We are trying to bring that into demonstration in a much wider geography as well, combining fortified food, social protection, and health system support, and also demonstrate the practical integration and nutrition into TB care. And then also look at, clinical TB management with food assistance and, also fortified staples as well. So, and in addition to that, there will be multiple components within that, which will also involve social behavior change as well, which we will be looking at as well. Yeah, the geographic focus right now for this particular project that we have kept is Indonesia, Bangladesh, Nepal, Timor-Leste, and Myanmar. These are the 5 countries that we are going to focus on in phase 1. Then, of course, WFP has direct food assistance in many of the countries that you can see on the slide as well. There are roughly around 12, 13 countries where we do have direct food assistance as well. And in phase 2, we can also think about, based on the learnings from this particular project, to expand it into other geographies as well. So, but this will be the starting point, and then we will look at phase 2 in terms of expanding into other geographies as well. So what we are trying to, look at, and what practical considerations we are also trying to bring through this particular project as well, in terms of making it work, is that, embed nutrition screening, counseling, and support into TB services, leverage social safety nets for food and cash-based assistance, coordinate local food fortification initiatives with health delivery systems, multi-sectoral collaboration, which is a very critical factor. Behavior change communication, as I mentioned, is also important, because we have to also promote in terms of the consumption of healthy and nutritious foods as well. Donor coordination and strong national policies. I mean, eventually this demonstration will also lead to the policy changes at the national level as well. So we hope to achieve that through this particular project as well. We are quite excited and with working with WHO on this project, because we fundamentally feel that this will add to the overall understanding and knowledge base of how in operations TB and nutrition program can be collaboratively implemented as well, and how TB programs can be made nutrition sensitive as well. And finally, the key recommendations which based on whatever studies we have looked at, is that we have to look at nutrition as central to the TB care, not peripheral. Mainstream food and nutrition into TB policies and budgets. Strengthen local supply chains for fortified staples. Invest in operational invest in operational evidence and impact documentation. Include household contacts in nutrition and TB prevention strategies as well. So these are some of the recommendations as well, and surely as we go ahead with the implementation of this particular project, we will come to know quite a lot of insights in terms of we are going with an open mind. There will be a lot of challenges that we will face in the implementation, practical issues, starting from bringing in different departments of the government, to costing, to budgets, to fiscal space for the national governments to basically incorporate something like that, and trying to untangle each of those issues in a very practical fashion, and also using the power of data analytics to basically see how we can advance on this in terms of the implementation process. Let me thank you for your attention, and any questions that you might have, please feel free to put it in the chat box, and the organizers will send it to me, and I will endeavor to answer them the moment I receive them as well. So thank you so much for your attention. Have a nice rest of the workshop as well, and apologies for the health issues that I have had. Thank you so much.
So we'll open the discussions later on after we hear 2 country presentations. So we'll be hearing from Bangladesh and Lao PDR. So first, I'd like to call on Dr. Zahangir Kabir from Bangladesh to share their experience on implementing nutritional interventions for people with TB in the household.
Good afternoon, everybody. We know that tuberculosis and undernutrition is closely related, and both are public health issues for the Bangladesh and all over the countries. And undernutrition and tuberculosis associated with both diseases increases the severity, frequency, and also fatality. I'm from Bangladesh. Some initiatives are taken for the Bangladesh tuberculosis control program. I'd like to share with you. Before that, I like to share with you the scenario of the tuberculosis in Bangladesh. According to the global tuberculosis report, we can see the total TB incidence is number 379,000, and it is 221 per lakh populations. It is quite high. That's why the Bangladesh is among the 13 high burden countries. And TB HIV incidence is 740 in number, and it's 0.43 per lakh population. And MDR and RR-TB incidence is 5,000, and that is 2.9 per lakh populations. HIV negative TB mortality 44,000, and that is 26 per lakh population. And HIV positive mortality 170, that is 0.1 per lakh populations. Now the national status of the nutritional status of the Bangladesh, it is also the malnourished children's, lots of the malnourished children's and pregnant women in our country. You can see the child stunting, that is a low weight for age. 25% of children under 5 years age indicating chronic undernutrition. And child underweight, that is a low weight for age, that is 22%. Children under 5, and child wasting, that is the low weight for the height, that is 8.4%. Children under 5 reflecting acute undernutrition. And coexisting forms of malnutrition, approximately 8.9% of children under 5 experience multiple forms of undernutrition. And maternal malnutrition, around 10% women of reproductive age are underweight, that is the BMI is less than 18.5 kg per meter square. Some progresses of the nutritional status towards the SDG, though with all the indicators we are behind the SDG targets. We can see within the Bangladesh Demographic Health Survey 2022, you can see the standing is 24%. It is the quite high over the targets of the SDG, that is 15% we have to achieve. And wasting in the 2022, according to the BDHS, it is 11%. We have to reach 5% within 2030. And overweight also, there is the we can see in the SDG target is 1%, but it's quite high, 1.5% is. An estimated number of TB cases attributed for the 5 risk factors. We can see the undernutrition is the major contributing factors, and others are smoking, diabetes, alcohol use disorders, and HIV. And alone, undernutrition contribute 42,000 TB cases in Bangladesh. Nutritional support TB patients in Bangladesh. We NTP Bangladesh implementing nutritional support, especially for all DR TB patients, all TB HIV co-infections, all poor and ultra poor, day labor, homeless, street beggar, river gypsies, and transport workers. We have already in the 2024 21,302 TB patients received nutritional support from the NTP. Some interventions, that is the cash transfer ability to 1,200 equivalent $10 for the each patient, and funding sources, the global fund is contributing for that purpose. And implementing agency, we have the collaboration with the BRAC, another principal receiver from the global fund. They are the contributing this type of support. And the geographic coverage, whole country is covered by this program. And nutritional counseling during treatment initiation, every follow-up we have done, and hospitalized patient contributes to free of foods, supported by free of foods. And National Nutrition Service has recently developed under disease-specific dietary guidelines, which is including TB. It is not published yet. I think it will be recently published and disclosed for us. Integration of the TB with IMCA Corner. We have recently integrated our TB programs with the IMCA program. The USAID Alliance for the Contributing TB Bangladesh, SETB, was facilitating active screening for the TB in the IMCA corners of the 19 secondary and tertiary healthcare facilities in Dhaka, Rajshahi, Sylhet divisions, as well as the 109 primary healthcare facilities in Rajshahi and Rangpur division. We have screened TB in the urban area, that is 390,000, and TB presumptive we found 7,000, more than 7,000, and presumptive tested more than 6,000, and all forms of TB found 433, and bacteriological confirmed out of them 55, and 301 was clinical diagnosed, and extrapulmonary TB diagnosis is 77. And the rural area, we have 5,75,000 was screened, and out of them more than 6,000 was presumptive, and more than 5,000 was presumptive tested, and all forms of TB were found 207, and 10 was bacteriology confirmed, and 148 was clinically diagnosed, and extrapulmonary TB was found 49. And total, we have screened about 9,66,000, and more than 14,000 was presumptive, and presumptive tested out of them 12,000, and 640 was all forms of TB, 65 was bacteriology confirmed, and 449 was clinical diagnosed, and extrapulmonary TB was found 126. Challenges of the nutrition intervention among the TB patients. The Bangladesh is a high prevalence malnutrition in there, and inadequate nutrition support programs in our country, and insufficient coordination between the health and nutrition sectors, limited funding for the nutrition focused intervention within the TB control program. We have some recommendation to improve the nutrition for the TB patients. We have to expand the food support program for all TB patients, not just for the MDR TB cases. Conducting regular nutritional assessment for the TB patients, and we have to raise awareness about the link between nutrition and TB recovery, and we have to strengthen the partnership between the health, nutrition, and social welfare programs, and encouraging the community-driven initiatives. If all the programs we integrated with the National Tuberculosis Control Program, then we have to overcome the nutritional status of our country, and the TB and with under nutrition is a more fatality, more frequency, we can overcome this type of problem. Thank you. Thank you all.
Thank you very much. We'd like to call on Dr. Sakon Sothepmani from Lao PDR.
Okay. Again, good afternoon. This is maybe different from Bangladesh, but we are doing the research for nutrition. We have cooperated with NTP and National Nutrition Center. Before going to the study, I just would like to highlight for PCAs first. There's a last few years, no, not a few years, it's 5 years. It's 2018 and 19 that we conduct TB patient cost survey. And this is some result that time that overall is for the TB that we know that's catastrophic cost is really high, that in DS is 63, and DR TB patient is 84, let's say 85, and of course is TB HIV co-infection is also high. And at that time, that's the survey also found that the major cost drivers was nutritional supplements. And again, that's we have recommended that systematic nutritional assessment counseling for TB patient as nutrition services is not provided at that time. Up to now, it's just for DR TB that we provide some support. Of course, the most important is that time we know that nutritional supplement is for DS is 35% and DR is 50%. We say it's TB not study. The objective of this, the aim is to assess the effect of nutrition, intervention of TB treatment outcome, and financial burden due to TB. We have very
focused on how to measure the prevalence of the malnutrition in people with TB, and let's say is a TB patient, and to examine the impact of nutritional support that's to be avoid of catastrophic cost by the household member. And again, this to access the effective to improve the nutritional status through the nutrition intervention on TB treatment outcome. And the method is we have the we do the study is all we random for a study. This is a facility based before and after trial. So intervention start with a cohort enroll means after registration of 4 months, and the duration is 15 months. The 6 months for enrollment and then 9 months for follow up. And sample size is quite small, but compared to the patients that are available in the system is okay. And so we have 335 people, and here is for 11 DRTB intervention group. And in terms of data correction, this we correct like patient cost, nutritional factor, clinical information, and every patient need to make appointment 4 times during study. This is the size of the study is a 6 central provincial hospital with large number where TB notifications high. And the intervention is we focus on nutritional counseling, and that we provide like RUTF, and of course this supplementary feeding by meal, drinks, and snacks for moderate malnutrition. The list now is we know that more than 40 of TB patients were low BMI. Is 18.5. Is more than 40%. And for upper is close to 60. But the fact that associated with undernutrition, where one is a drug-resistant TB, an experience of hospitalization, means during the care sick king, and with provided weight loss or under poverty line. This is and again for people with rural area, but unfortunately this study we don't focus to rural area. Maybe it's higher than that's simple scientific correct information here. And we know that the effect nutritional intervention on TB treatment outcome also is nutritional intervention was not associated with the treatment success among intervention group and observation group. It's a really same. It's a 90%. And nutritional intervention was associated with early BMI normalization. Recovery of BMI is let's say this is quite means when we provide that intervention is we can recover the BMI is faster. And the intervention group had lower cost compared to the observation group, of course, because when we provide some supplementary, we provide some food. They're not going to buy any additional things. This compares in a number of the is 110, 8 and 169 is quite different here. And of course, this is income lost accounted for 65 for total cost. Again, this is the factor that's associated with lower percentage of the catastrophic causes. One is the early TB diagnosis, and high BMI at the TB diagnosis, and nutritional counseling and support, and high household income before being a patient. And here is just like we compare observation and intervention. Observation is a 64, is a lower catastrophic cost. For intervention is all 30. After this research that we have discussed with CDC, discussed with communicable disease committee, of course, we would like to include this systematic nutrition assessment for counseling for people with TB, and again, we need to have like capacity building for healthcare workers, where they provide TB services at health facilities, and to make sure that BMI data is available in the system. Like we now develop like DHIS2 is TB tracker to capture all information related to BMI. And again, we also need to do more that advocacy for policy dialogue to enhance the national TB and national policy in terms of nutrition supports. And again, that's for that we have to discuss with NNC, is the National Nutrition Center, how to link with how to integrate other programs like MCH and others. But of course, there's collaboration and coordination with the other sector, other disease is very important. And CSO is one key player role that they need to be involved for community engagement. And one main activity is active case fighting. We need to more for the team to search for TB to early diagnosis. And of course, this the study is without of the WHO to the country, VPRO and the headquarters, and of course is CDC, DHR, and all related department that we cannot success. So I just appreciate and thank all of these stakeholders to be part of this research. Thank you.
Thank you very much, Dr. Sakon, for a very interesting and informative information from the presentation. So I think we had policy updates by WHO. We have implementation consideration from World Food Program and 2 presentations from the country with very interesting data. So we now open for questions and discussion. If you have any questions or comments to all the presenters. You can come over to the microphone there.
What their experience of
all right. Yeah. Maybe
someone has a question.
Yeah.
Yes, Dr. Zhang.
Okay. Thank you so much for presentation for the nutrition program in Bangladesh. Can I have question? So first is how long does it last? The program for the TB patient, and what kind of more specific, what kind of food or food stamp you provide for the TB patient? Thank you so much.
Thank you. Thank you. You know, we are food supports for the only the MDR patients and recommended by our nutritionist and all the doctors are prescribed what type of food he needed. That type of food is supplied to the MDR patients. And when the patient is admitted in the hospital, the food is supplied by the hospital, and that's the nutritionist food is supplied to that patients. And otherwise, in the we support the cash also distributed to the MDR patients, and we prescribe them this type of food should be taken by the patient.
Okay, so that means when the MDR patient in treatment, you will provide the food for the whole treatment, right?
Yeah.
So for example, 10 months or longer, right?
It is provided by the conditions of the patient. When the patient is stable in conditions and under the nutrition condition is improved, if the patient is able to work, and then the support can be stopped, but otherwise the support is continued until the treatment.
So usually how long does it take?
6 months.
6 months, okay, thank you.
Thank you.
Yes, please.
Just one more question for you. Actually, 3 questions for you. One is, you mentioned there's $10 which is provided as cash transfer to TB patients. Wanted to check, is that for private sector patients as well? The second question is, how is this money being transferred? Is it like a bank transfer or some other mechanism? And the third question was, what's been the uptake? I mean, what's been the coverage of this? Like, is it like 100% or is it less than that? Can you just explain, talk about that? Thank you.
Okay, thank you. This support is supported by our another stakeholders, like BRAC is responsible for that supports, and the fund is distributed by the Global Fund directly to the our PR2 principal receiver to BRAC. They are doing this type of support to the community. And the food support is not only by the BRAC, another our social support network is also available. We have in the community vulnerable group feeding. When we recommend our authority to give that type of support to them, they also support that patients. And we have another social welfare department in our country. They also support this type of patients. When doctor recommend to them, they also support this type of patient. And otherwise, we have that in the TB program, BRAC has the fund which is collected from the Global Fund. They distribute to the fund and keep the records to them. And when we'll supervise and monitoring from the TB program, NTP, they show us, and we directly, in the community, the MDR patients are not so much. There are 2 or 3. Our Upazila Health Complex, the administrator is called the USFPO. He also supervises that type of support, and the district level civil surgeon is supervised whether he is getting that type of support or not. And another question was last one.
What's the uptake?
I don't exactly what how many patients are supported by that groups, but the MDR patients are socioeconomically they are the low and the poor, ultra poor patients are. I think every MDR patients are getting this type of support in Bangladesh.
So just want to clarify. So the $10, it's a bank transfer that BRAC is doing, or is it like a cash?
I think it is. We know in our country that type of people, that are low socioeconomic, they have not the bank accounts. They are getting their supports in the directly, but recently we are taking some online banking system, mobile banking system. They get the support from that. We are transforming the authority to give this type of support to the bank, online banking or mobile banking system. Thank you. Thank you.
Yeah, I have a question. Yeah, sending to you. Do you observe any stigma related issue you based on the food support or the cash support they are receiving?
Regarding TB patients, especially the MDR TB patients, there is still in Bangladesh there is some social stigma that if the patient is recovered from the disease, they have to wait some month or few days to involve in the work. That is the stigma in the authority that hesitate to permit him to in his work. But in the distributing this type of support, there is no stigma, because the NTP and BRAC are always working with this type of patients, and we are working against the stigma. That's why our health workers they're out of that stigma. They're giving service happily. Thank you.
Okay. I think it would be really interesting to find out which the countries in the room, I'm going to do a Grania, and see who is implementing TB and nutrition activities currently. It's obviously not going to be the upcoming guidelines, but according to the guidelines that came out in 2013, we've heard a brilliant case study from Bangladesh. So I just wonder, I know Nepal, perhaps. I think you're doing something. Would you like to sort of add and perhaps say what sort of support it is and which your partners are? That would be really nice, and we can do a tour of the tables to go to the other countries to see what the baseline is. Thanks very much.
Thank you. For Nepal, our government of Nepal giving 300 Nepali rupees, that is around $25 per month to the patient as a nutrition support. And this is a cash transfer, not cash transfer, it's bank transfer. Bank directly goes to the patient's account every month. For government, it is very difficult to procure the rice or something like that and give to the patient. That's why they just transfer the money into the account. Every month they are getting 3,000 Nepali rupees, that is $25. And for the DRTB only, for all the DRTB. And for DSTB, drug sensitive TB, we have a huge burden and like 70,000 cases every year. So we cannot, the government of Nepal cannot support every patient, and every patient is not needed also in the DSTB. So for poor and ultra poor patients, the patient who is a very poor and it's ultra poor, like homeless or something like that. So for them, we are supporting 500 Nepali rupees every month as a nutritional support. This is all done by the government of Nepal. No any global fund support or any USAID support, nothing. Just the government of Nepal is supporting that. So next, I think Cambodia.
Yeah. Thank you, the Nepal. From Cambodia, we have the support for the MDR TB patient only, but for drug accessibility, no. As you said that we have many cases was enrolled. For the MDR patient, we support from the Global Fund, $30 per month. The budget is transferred to the account, and this before moving that they have the local NGO. They provide directly to patient, and later on to avoid something happen, then now the money transfer directly to the account, and the local NGO to monitor to ensure that the budget will be used for the food for the patient. Thank you.
Yeah.
Who can speak for Vietnam?
Any from
So actually, in Vietnam, we provide food support and for MDR TB patients during first 50 days of hospitalization, and for some special case like if they are operating, we also have
additional support. We did around $50 a month until the end of the achievement. And for some social civil organizations, they also have a kind of tool that assess TB patient whether they met very specific checklist, whether, and then they decide to provide a package around 3 million Vietnam dong for a patient. And some other organizations, they also provide a kind of food package for the TB patient. We have very, kind of food support for either DSTB and DRTB. I also have one question for Nepal, because from the presentation, I saw that the undernutrition is high. So is there any plan to integrate the food support into the food security at national level to reduce the rate of malnutrition, rather than thinking just focus on the TB patient?
Sorry, your question is to which country? For Nepal. Dr. Navin, a question.
What is the question, sir, please? I don't.
So I saw that the malnutrition in your country is high, right? The challenge, one of the challenge is the malnutrition is the high.
Bangladesh or for Nepal?
Sorry, Bangladesh, the first one. So the malnutrition rate in your country is high. So is there any plan to integrate the food support for TB patients into the food securities program in your country?
Yes, we have some programs in Bangladesh. There is the vulnerable group feeding, and another social network supports is there. When social welfare department, we recommend to the patient to support that type of facilities. They are availed that type of support from the social welfare department as well as from the vulnerable group feeding. We have the social safety net program in Bangladesh, and from the NTP, we are now integrating that program with the NTP. Just we are coordinating this, but until that, if our authority NTP or in the sub-district level, the USFPO recommend the patient to take some support from that department support the MDR patients also. Okay, thank you.
PNG.
Thank you for the presentation. Nice presentation. For PNG, yes, we have food support, and food it comes in food vouchers. So the Global Fund is supporting us. So the money is being paid into a business organization, and the patients go and get their food baskets from there. So that's how we operate in PNG.
Mongolia.
Thank you. In the Mongolia, undernutrition percentage of people very low. Just 3% of TB patients have malnutrition, and we implemented for nutrition programs supported by Global Fund since 2007. And two NGOs implemented this program. This program included 2 or 3 activities. Give the food vouchers for TB patients and daily food support. And we also included our food support program and social protection activities included in our new NSP.
Thank you. I understand that you also do lunch dots, like you invite patients to have lunch in a restaurant. Is that daily or?
Yes, like this program, daily dots lunch program, but currently quite changed for activities.
Thank you.
Yeah, actually, I have one remark and one question. Again, a question to all of you. But the remark first being that in the case of tuberculosis disease, we are talking about people who lose weight during a short period of time, but they may still be quite, if you look at them or you take their weight against height, they may still be way above all boundaries, but the very fact that they lost 5 to 10% of their body weight in a relatively short period of time, like 3 or 6 months, represents undernutrition. So if you're saying that in general, among TB patients, malnutrition is a certain percentage, I do not know if you mean that that includes the people who lost weight significantly, but still are of good posture. And so I think that is something to think about. And that even someone of a relatively high body weight may still be undernourished because of having that weight loss, and they need nutrition, even if their weight is not bad, but they still need additional nutrition in order to be able to cure themselves. So that's one. The second point is you're all commenting, I think, if I heard well, you're all commenting on the programs that are in place in order to support people currently having TB. But I do not think that you were really presenting about nutrition for household contacts. And that's a different approach, nutrition for household contacts in order to prevent them from getting TB in the first place. So can you comment on that?
Bangladesh.
You know, the Bangladesh is a high burden country, and the DSTB is a high burden in our country, and the households are also, if we count every DSTB, there's a 4% is a household average in the whole of the country. And nowadays we have no program to give the DSTB the food supports and the financial supports of DSTB as well as the households. We are only supporting the MDR-TB and those who are the DSTB ultra poor, day labor. Those are the entitled for the support. Now, yeah, not all DSTB and all households are not getting this part. But if your recommendation is, of course, it is a excellent recommendation. That if we not giving the household this type of support, they are the malnutrited, they will be easily, frequently affected by the TB, and the TB incidence rate will be increasing and increasing. If it is possible, every country should give that support not only to the MDR-TB or every DSTB as well as the household contacts. It will be benefited for all the countries, but in the logistic and financial constraints, we can't give it to all the patients and household. Thank you. And our donor, the Global Fund, also contributing for only the MDR-TB patients.
Okay. Yeah, just make a comment on that. And I think this is an interesting one. I mean, you know, in the previous recommendations, the previous guidelines, there was a recommendation on screening and assessment for undernutrition in household contacts. And if they were found to have TB, undernutrition, to, you know, make sure that they were, the undernutrition was addressed. The question is whose responsibility? And I think, you know, I think this is something that is a massive thing, because especially in the existing financial climate, it's I think
probably, I mean, I wish India was here today. Maybe they can speak tomorrow on this, but I think, you know, there are countries that have actually got sort of multi-sectoral MAF TB representatives who make sure there's a liaison between the sectors within the healthcare system and within and outside the healthcare system. And I mean, I think this is where MAF TB hits the road, you know, the rubber hits the road, and it's really proper multi-sectoral collaboration. And we cannot think of this as just the TB program's responsibility. And I think, you know, this was what was mentioned by Arvind from WFP. And I think, you know, there's a really nice sort of guidance that's come out from SEAR WHO on, you know, on lobbying for support, for advocating, you know, within government and making sure there is a liaison, and also looking at TB affected families as those that are eligible for receiving food rations and food assistance. And I think probably it's worth thinking about, you know, where you need to do a stakeholder analysis in country. And it's really lovely to hear that, you know, Mongolia's come up with examples, you've come up with examples in Bangladesh. And I think you're all using different partners. There are partners in country who deal with food assistance. It's just, and they don't think about TB. So I think we just need to advocate a little bit more and start trying to join up the dots and making sure there's universal health coverage to good nutrition.
Thank you. Your suggestion is absolutely correct. You know, our National Nutrition Service already developing the food supports for the countrywide undernutrited peoples, and TV program is included in that services. But this is the strategy is yet to be published. When it is published, I think National Nutrition Service also contribute in this purpose. And another thing you have mentioned that the multi-sector accountability framework in which we can involve the other than health ministry to other ministry will be involved in that program. Yes, the Ministry of Women's Affairs, they're contributing to the lactating mother and pregnant ladies. They're giving some supports. We will introduce the TB program with them, integrated with them. And others, the Ministry of Labor, the Ministry of Commerce, they should be involved in that program. We are trying to develop the multi-sector accountability framework in Bangladesh. Just we are approaching. We have published handbooks for that, and we are now arranging some advocacy programs with them. After that, we think not only the TB programs will support that type of patients, that other ministry will be support the undernutrited TB patients as well as other undernutrition populations. Thank you. Thank you.
Thank you very much. Can we hear from Indonesia?
So for Indonesia, the TB and nutritional support we have for DSTB, but it's sporadic. Partly this is mostly in the district. They'll already have the what do you call it, local district action plan for TB, because they can utilize the local funding for that. But for the district that haven't had this, they cannot utilize the local funding. So this is for the DSTB. And for the nutritional support, it's in primary level care. We call it puskesmas. They give milk to the patients. For the RTB, it's a different scenario. We do have support for the patient, but it's called enabler. That's for transportation. So to make sure the patient come to the hospital regularly every month. And in some hospital, they do have collaboration with CSR. So the CSR, they provide meals or food basket for the RTD patient each month.
Thank you very much. I have two comments or questions. The first, we've heard a lot about cash transfers. So I'm just wondering how the monitoring for this is, because it will be two levels. Like, so they receive the money to their accounts, and so we have to make sure that they use that money to buy food. And how do we monitor that the food that they buy is taken by them and not shared with the rest of the families? So So it's a monitoring question from me. And the other comment I'd like to share is we've also heard that nutritional support is more for DRTB, but why? I mean, it doesn't mean that if you're DSTB, you're not malnourished, you're not stunted, you're not underweight. I think it stems from the fact that DRTB has always been viewed as the more serious kind of TB because of the long treatment. We started with 24 months, but now they're both 6 months. So yeah, I think we should think about that the parameter should not be really whether you're susceptible or not, but it's whether you have undernutrition, whether you're stunted, or and the other parameters. My thought.
And I'll just make a comment on that last comment. I think that's exactly right, and that's what the GDG recommended in the latest guidelines. That it's regardless of, whether you're with DRTB, whether you're under 5, whether you're pregnant, or whether you're, whether you're HIV positive. So it's based on the fact whether you have TB and undernutrition, defined as, according to the WHO, a BMI of less than 18.5 for adults, and then Z scores depending on the age group for adolescents and children. So, your question on the monitoring of the correct use of funding is a really key one, and I think during the operational guidance, the consultation that we will be conducting, we will be asking exactly this question, but it would be very interesting to hear from countries who are making those transfers, because I know WFP are very much moving towards cash transfers, and the logistics of food is quite big and quite costly. So I think, I don't know anybody who can anybody give us, because sometimes it's conditional cash transfers. So it'd be interesting to hear if anybody's got some input into that question.
Maybe we hear from Sakon from Lao, because you do cash transfers, right? In your presentation, how do you monitor that these cash transfers are used the way they're intended?
I think that's for nutrition support is a long story, because depends on that each nation. It depends on each context of a country. For example, that's wherever we faced with a financial crisis, is like in Laos, that we cannot, particularly is NHI is not covered for TB, and also the health insurance is something that where many states that we have to discuss more, but any conclusion. They would like to support, but is funding limited. It's just putting in the document, but in practice it's nothing. See. But for us, of course, that's DR is I agree with all the colleagues that we need to keep going to support DR TB. Why? Because it's complication with DR is more than this. But anyway, in terms of this research, is as you know, that's is in Laos more than 40% is lower the BMI, and these people not just taking die during the treatment, but they have to it's effect to treatment, maybe take too much time, or it's a effect to the household income. That in conclusion, that's we don't have any clear about the further planning with the TB program, because many things that the government need to consider in terms of limited of funding from government. Thank you.
Yes, Agnes, thank you, Sakon.
I'd like to ask your, to not, maybe not to challenge you. I don't want to challenge you, but I want to ask you a question on it. Because if I correctly saw one of your slides, your third or fourth slide or so, then you had the guideline committee had judged these studies, and one of the results of cash transfers was also a moderately positive effect, etc. And I know from earlier discussions in the past with especially also with community representatives who say, yeah, people have wisdom in using the money. They will decide themselves what the best use is of that money. And supporting families overcoming their financial difficulties, one of the effects of that having maybe better nutrition, that is up to the families to decide what their best use is. So I would not be against cash transfers, even if you're not really able to monitor which cent is spent on nutrition and what on something else.
No, and I agree with you, Agnes. I mean, this is something that is there and it's out to be discussed. And in fact, WFP, I mean, I've had discussions with WFP on this. You know, they were saying, oh, you're recommending a food basket, but we're transitioning to Bitcoin. Or to direct transfers or mobile money and that sort of thing. And, you know, the costs of and logistics of food is massive. And I think, you know, that the good thing about money is it empowers as well. I mean, there are so many positives about that, and that people who are poor are much better at budgeting than people who are not so poor. So, you know, there's that. There are, of course, you know, concerns about cigarettes, alcohol, you know, substance use, and maybe that is something that needs to be judged on a case-to-case basis, although that may be slightly more complicated operationally. So these sort of things need to be taken into consideration. Another key thing is about transfers is how much. Is it enough to meet the food needs of, you know, and I think, you know, if you look at the rations trial, they didn't actually trial the patients. That wasn't randomized. That was in a nested cohort. But, you know, they were given 1,200 calories. And I think it was 72 grams of, I think it was of protein, whereas it's 23 for the household contacts. And, you know, I suppose you've got to think about the protein content and all those sort of things. And so that needs to be assessed at a local level. But again, I think it needs to be done in collaboration with partners. The Ministry of Health, who, you know, has the nutrition team, they should be helping on that, and also the other stakeholders. But the transfers, I think, you know, that how much, I mean, you know, you can be saying we are making these transfers to people who have TB, but is it enough? That is a question. And so, and those, and also, should it be monitored, or how much, and, you know. So I think, you know, we've got a lot to discuss for the operational handbook, as I said. So I'm looking forward to input from people. If you can share, I would be very grateful, because I think, you know, you've got the experience. Thank you very much.
Still in relation to cash transfers, yeah, I think it's not just about being accountable or making sure that it's for the intended recipient, but I think if we're measuring the impact, it can be a confounding variable if it's being shared with other members of the family. I think it's more of that. How are you able to attribute the success, or not success, but the improvement of the patient to nutrition?
Mansa informed me that a colleague from Indonesia have a comment or question in the chat. Do you want to speak? Online.
Online.
Oh, sorry. The colleagues were online. So please go ahead.
So please go ahead and share your question, whoever wrote on the chat box.
Good afternoon. It's not questions, actually. It's adding information while we are discussing about the nutrition support for TB patients. So, yeah, Indonesia, as you know, is currently have TB program as part of the Quick Win program from our new president. And we are in discussion with the coordinating Ministry of Human Development and Cultural Affairs, and also Ministry of Social, to give the provisions of nutrition support for TB patients, which will be integrated with the contact investigation through this Quick Win project. We also have a discussion on guidance on TB at the village level, where we will incorporate the nutrition support in the initiative in the village level. As you know that during the multi-stakeholder framework, we also have support from the Ministry of Village, and we would like to utilize this support for giving provision of nutrition for the patient. But again, this is still in discussions, but we feel optimistic that we can go through with this discussion, especially after this meeting. We will update the information we received today along with the Ministry of Human Development and Cultural Affairs and Ministry of Village and our Ministry of Social.
Thank you very much, Regina, for your input from Indonesia. Yeah, I see Dr. Zhang have hand earlier, but he's not here anymore. So I think it's time now. We better close the meeting because we also have time to move for dinner. So I'm not sure if Mary want to say anything else before we close.
No, not really, but just to thank Annabelle for sharing with us the WHO updates on TB and undernutrition. Let's give her a big hand. And our colleague from WFP and our presenters from Laos and Bangladesh. And thank you everyone for the active participation. See you all tomorrow. Thank you.
Okay, thank you very much, everyone. And thank you, Mamel and Lynn, to agree to chair this session on the last minute. So we're supposed to have the wrap up of this, the day. So, but still we have the continuation of the session tomorrow, because tomorrow in the morning we'll have the group work. So maybe Mamel and Agnes, after that group work, maybe we can have a quick wrap up of today's day. So regarding the dinner, so the bosses are coming here. So at 5:45. So and we expect to leave at 6 o'clock. So and the travel time is okay. They say 30 minutes, but depending on the traffic, so it can be 1 hour. So and the plan is that from 7 to 9, so we'll be in the restaurant. So and we'll come back. Okay, so and please, they said that don't forget to have your name tags with you. Okay, thank you very much and nice evening.